Mixed Cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
And good afternoon, everyone, and welcome to PerfWeb 30, Part 3, Day 4. So we're on our 14th in a row programs,
wow.
Monday through Friday.
Mm-hmm.
Tomorrow will be our 15th, and we will have accomplished our 30 CEUs, Category 1, of course, live, with the ABCP. So hopefully it was able to provide some relief to some of our colleagues. You were just telling me about the AMSEC meeting calendar. Could you tell us again?
I looked on it today because I was going to probably try to attend the CREF meeting. Of course, you'll see that all on its own accord. But I noticed today that all the meetings for the entire year of 2020 have been canceled. There's not a meeting now that they have on the calendar of events until 2021.
2021.
Yeah.
Wow.
Yeah.
Wow. Well, hopefully we're able to fill that void. We were talking about it a little bit. I think that conferences are good. I think that there's a double benefit, right? We all work really hard, and I think going to a live event, you get a little downtime. It's kind of like a working vacation, if you will. Although the intent is supposed to be education. You should go to as much of the meeting as you can, understanding there's going to be times when, you just don't. But at the same time, it's also a great opportunity to meet new people, see old friends, collaborate, be sitting with somebody at a table, listening to a presentation, and actually having dialogue about the talk that's being given. So I do think there's a lot of benefit with live conferences. That right now, as it sits, we can't provide that.
Right.
But with that said, and you'll be interested to hear this, I think hopefully you will all too, we're really trying to figure out how can we create that virtual environment. And we're trying to figure that out, where everyone out there that is participating, that chooses to, of course, that would be their decision, could be live in the studio from wherever they are, where we can see everybody, but not in the same way that Zoom does it or WebEx does it. It's a little bit different, but I think it's doable, but it's gonna take, I think the technology currently exists. It exists at a different level, and how can we take that and adapt it to, you know, our circumstances. So
Right.
it exists to do it, but it's kind of, you know, edgy as to how we can make it
Right.
work in our environment, and also very expensive, as you could well imagine. But there's, as time goes on and these problems keep presenting themselves,
Right.
I think this is going to push that technology farther along faster than had this not happened.
Most definitely, yeah. I agree with you.
I think so. So anyway, let me go here. So our sponsors, we need to thank them. Please check them out. LivaNova, Siemens Diagnostics. They are primo. Without them, we wouldn't be doing this at all. I can guarantee you that. Social media. Please like us, follow us, share us on Facebook, Twitter, and LinkedIn, and also subscribe to our YouTube channel. Give us a thumbs up and click the notifications button so that you can get notifications if we do an ad hoc meeting, like we just do one that wasn't planned. It's a good opportunity for you to know we went live, because we may do some neat, we're going to keep evolving and doing neat stuff in the future, some fun things too, not just intense work, you know, just that intense stuff. Do fun stuff too. I want to really try to make this experience unique to anything else that's out there, and I enjoy it. You know, to be honest with you, I just really enjoy doing this, and that probably helps quite a bit.
It does.
Check out our websites, perfweb.us, perfusioneducation.com. Look them over. There's a bunch of information in there. I'm not going to belabor the point, but those are our sites. Check them out. Call-in number, when you see this symbol, you know that the phone lines are open. Oh no, so did I go ahead of myself? No. Oh yeah, contact it at, that's an email. If you want to join our faculty, you have a topic you want to discuss, or whatever it may be, you just want to reach out to me to tell me how great I am, which is always appreciated, more than welcome to. Contact at perfusioneducation.com. Now comes the call-in number. Apparently I got ahead of myself or behind, one or the other. There it is. You see that symbol right there? You know the phone lines are open. You can call, be live on the air. We can hear you. The audience can hear you. We can talk to you. And it's a great experience. I'd love to hear from people today, be live on the air. I think that's all for my housekeeping notes. So right now, what I'd like to do is, if I could, I'd like to introduce the people that are going to be on the show today, okay? And I'd like to start, if I may, with Michael Ray Brown. I didn't know your middle name was Ray.
That's
Michael?
it.
Mike
Yes.
Brown? Otherwise known as Mike Brown, or now the notorious MRB.
That's
so I think
right.
we're going to call you the notorious MRB from now on. Mike is a 1982 graduate from the Texas Heart Institute School of Perfusion. Prior to that, you received your Bachelor of Science degree in nursing. I didn't know that. You know what? I've just learned two things today that I didn't know.
Yeah.
From Baylor University in 1982. Damn, you're old. He has been a perfusionist for over 38 years in and around the city of Houston. You served as a clinical instructor at THI for 11 months after your graduation. And in November of 1983, you joined Houston Life Support, providing perfusion services in the Houston area for over 30 years. Right. You've worked with HET as a clinical perfusionist since 2014. We hope to keep you around for another 40 years if it's possible. You were instrumental in the development of the CPS system for temporary cardiopulmonary bypass and placed the first patient on that device in the country. That's a big milestone, and why I'm glad you're here today with this topic, because patient selection is my thing, but I think you're going to be real interested too in John's presentation on the right-sided circulation, but also the anticoagulation. You've been involved with the Medicines Company to perform clinical trials and protocols concerning the drug Angiomax. You provided relief services to 12 hospitals in the United States and in Puerto Rico, as well as 2-week perfusion medical mission in Perm, Russia. I remember you gave that presentation at the New Orleans conference. It was great. You also serve as faculty for PerfWeb, which we appreciate so much. And you describe the most inspiring part of your job is seeing patients do well because of your efforts in the overall care of the patient. And when there's downtime, you like to spend time with your family, who are really great, as well as traveling and hunting.
Right.
So that is my good friend, Mike Brown. Now, I'd also like to bring in Rodell Ebus. Rodell, what's your middle name, Rodell?
I don't have one.
Doesn't surprise me. Rodell received his post-baccalaureate degree in perfusion technology from also THI. We got the THI day today.
Oh, yes.
And at, of course, St. Luke's Episcopal Hospital, Houston. In 2002, you have close to 20 years of experience in perfusion. The first 15 years of your career began in your hometown of Detroit as a staff perfusionist and then a clinical instructor for the perfusion technology programs for the Ohio State University and Rush University. He is now back in Houston, and we're glad you are, I can assure you of that, and currently working with HET, doubly glad for that, as a perfusionist and frequent contributor in continuing education via PerfWeb. He feels the most inspiring part of his job is having a hand in the extension of life through the treatment of end-stage heart disease. When Rodell is not working, he enjoys spending time with his wife and family, who are also great. He likes to travel, do yoga, goat yoga, I'm assuming, exploring new places to dine. Yes, he is a foodie, not quite as much as Nate. I think Nate's really kind of out there. You like to attend concerts, do spin class. You're an abusive husband and bought your wife a Peloton. Compound target archery, which I thought was very interesting. He is an archer. Is that the right term? An archer? Yes. Or an archerist?
Archer.
Archer, yeah. And shooting and other shooting sports. So welcome, Rodell, and thank you for being here with us today. And then, of course, there's John Ingram. There you are, John. It's good to see you. You look dapper as always.
Thank you.
I've introduced John now. This is the 14th time. John, I'm going to sort of glaze over your introduction, other than to say welcome back as a frequent contributor to PerfWeb and somebody who I have come to lean on and appreciate your very sage advice, and in particular your incredible and your outstanding clinical expertise. And I will tell you that between you and Mike Brown, you both carry a tremendous amount of weight. And Rodell, you're no slouch, okay? But combined, these guys have, they have over the life expectancy of any human being combined. And so that's a lot of years of experience, and it shows. It shows. Rodell, you still have hair.
Yes,
Mike, you actually do have hair.
I do
can't
have
argue
hair.
you don't have hair. I can't
I had
argue
a lot
you
more a few weeks ago before I finally got a chance to get a haircut.
Exactly. But it is kind of thinning up front. Rodell's is still really thick, and it's got a little gray in it.
Yeah.
Rodell has a little gray too.
Gray, actually.
But I have a feeling, I think his are highlights.
Yes. Yeah.
They are. I think so. Okay. So now I think we're all squared away on introductions. I think we're ready to move forward. And what we're going to do, we did change the schedule up a little bit. John is going to start off with understanding the complexities of right-sided circulation. And this is going to be a fascinating talk. I think we assume a lot about the right side, but by inference to the left side. But I think we're going to find out that we're not right on that. And then I'm going to do ECMO patient selection and complications, ECMO complications part one, kind of combined, one right after the other. Take a short break. John's going to come back with ECMO anticoagulation. I'm going to wrap up with ECMO complications part two. We're going to have some open discussions, and we're going to be wrapped up, and we'll have finished day 14. So, John Ingram, without further ado, please go on with your slides.
Hey, welcome, guys. You got me surrounded by some real heavy hitters here, Joe, today. So hopefully I can bring you guys with this talk here that me and Joe talked about not too long ago. I had this idea because I was reading up on some things about this, and I really kept finding some pretty neat surprises that even I myself, either I didn't know or I'd forgotten, or I'm not even sure I ever even totally learned it. So I'm hoping that as routine as this might sound, I'm hoping to surprise you guys a couple, 3 times maybe in this lecture a little bit. And at the end, you can tell me if I accomplished that or not. So, okay, so I see our title slide is up. So basically, I'm going to do an outline here, understanding the complexities of right-sided circulation. And I don't have any disclosures on that. So let's take a look at the outline. And what I'm going to do, I'm going to do a little introduction, but in this introduction, I'm going to pose 3 questions, and you're going to see what I mean by that, and hopefully in this lecture, we're going to answer those. And these 3 questions are answers, are questions that all of us here automatically assume we know the answer to. Pretty sure we thought we've known them for a long time, and hopefully I'm going to find out some things, like I said, maybe some surprises. First I'm going to hit the pulmonary circulation. What is it? The anatomy of it, the physiology of it, and some of the complexities that it offers us, or throws in our way, I should say, when we do extracorporeal circulation. And then I'm going to do the same for bronchial circulation. The anatomy, the physiology, I'm going to talk about what it is and what are the complexities for that come our way for extracorporeal circulation. Then I'm going to talk about the right ventricle and go into a couple of little interesting things, hopefully about that, and then we're going to bring it all together, answer those questions in the introduction, and try to see if we can have some nice conversation at the end. All right, Joe? So I said in the introduction, we're going to ask 3 questions in this lecture, and these are all questions that we all thought we knew the answers to, but we're afraid to ask. That's what I call them. So here's number 1 we're going to be talking about. So knowing that all the blood entering the left atrium comes directly from the pulmonary alveolar capillaries, why does the oxygen saturation in the left atrium never reach 100%?
I know why.
Go ahead, Joe. And number 2 question, knowing that our blood circulation is one big circle, hence the name circulation, and the right and left ventricle are in series with each other, one is behind the other, feeds into the other, why do medical textbooks say, quote, right ventricular output is approximately equal to 100% of the left ventricular outflow? Go ahead. And number 3 question, every organ in the body experiences infarcts. Anything can have an infarction. However, the lungs are extremely resistant to having infarctions. In fact, when is the last time you heard somebody say, this patient had a pulmonary infarct? And why do you think that is? All right, so let's dive in a little bit, Joe, okay? So here, I'm going to expand upon question number 1 a little bit, so you're not just taking my word for it. Knowing that all the blood entering left atrium comes directly from the pulmonary alveolar capillaries, why does the oxygen saturation in the left atrium never reach 100%? Well, here's the famous Anatomy and Physiology book by Tortora, 2014 edition, and he quotes, ever wonder why the oxygen saturation is not 100% in the left atrium and left ventricle? And down at the bottom, a journal in 2009, National Jewish Health, also says, healthy individuals at sea level usually exhibit oxygen saturation between 96 and 99%. Again, we cannot seem to hit that 100% mark. Go ahead, Joe. If you do a search and you go on Google or whatever and bring up diagrams of the left ventricle and the blood saturations in the heart, you'll see there, and you can find a lot of these. It's just 2 I picked off. And you can see there on the right, it says the left atrial saturation is 97%. The one on the left says the left ventricular saturation is 96%. Now, I just want to make a side note. You can find readings and you can find diagrams like this that say the saturation is 95 to 100%. You might even find some that say 100%. But if you do, those people are being loose and fancy-free with the facts. So, but you can find it.
Do we get to answer this question and win a prize, or are you just
we're gonna answer it all at the end together.
Okay.
Yeah. So now a little bit about number 2. So these aren't just things I'm making up. What about the right and left ventricle are in series with each other? Why do the physiology books say right ventricular outflow is approximately equal to 100% of the ventricular outflow? Well, this is Levitsky's Pulmonary and Physiology 2018 medical textbook quotes this exact saying right here. And in number 3, I think is next there, Joe. So why do we not ever hear about, or very rarely, a pulmonary infarct, or this patient had a lung infarct? We hear about myocardial infarct, strokes, and a million other areas that can have a stroke or due to a blockage or ischemia, but why hardly ever in the lung? Well, lung infarction is what you would think. It's death of lung tissue due to a lack of adequate blood supply. The section of dead tissue would be called an infarct, resulting from an obstruction like a clot or an air bubble in a blood vessel that serves the lungs. And here, an Encyclopedia Britannica even says this, in healthy lungs, such blockages fail to cause death of a tissue, i.e. an infarct, because the lung tissue is perfused by alternative routes. We're going to take a look at how that is. All right, so there's the three questions in the outline. We're going to start off with the pulmonary circulation and work our way down. Go ahead, Joe.
Oh.
Yeah, I just wanted to remind you guys. So, the pulmonary circulation. The pulmonary circulation transports poorly oxygenated blood from the right ventricle to the lungs. We know that. The main pulmonary artery, which originates from the right ventricle, gives rise to the pulmonary circulation. The main pulmonary artery bifurcates into left and right pulmonary artery in order to service each lung. Eventually, it becomes a dense network of pulmonary alveolar capillaries, where the blood releases its carbon dioxide and gains oxygen, which binds to the hemoglobin inside the red cells. And pulmonary alveolar capillaries empty into pulmonary veins, which carry oxygenated blood back to the left atrium. All this is an anatomy review that we all know. And if you wanted to see what it might look like in some type of fancy diagram, you see the right arrow there leaving the heart, the pulmonary main artery, and it goes out to both the left and right lungs, and a vast network of capillaries as blue blood comes back oxygenated, dumps into the left atrium there, that red arrow. All that oxygenated blood comes back into the left atrium. That's our pulmonary circulation. So let's look at pulmonary anatomy real quick. Well, it starts off with the upper structures of the nose and the pharynx. The pharynx is a nasopharynx, oropharynx, and laryngopharynx. These structures filter, humidify, and warm the outside air. They also help us equalizing our ear pressure. Then we go down to the lower respiratory system, and these lower structures are the trachea, carina, where the trachea bifurcates, bronchi, bronchioles, or alveoli. The lungs encompass the entire thoracic cavity except for the mediastinum, which is the heart, major blood vessels, and the bronchi and the esophagus. So that gives us some idea what we're looking at on the anatomy side. And then, of course, we have two lungs. The right lung is divided into three lobes and is actually larger and performs 55% of the lung activity. And the left lung is actually a little bit smaller, and it's in two lobes, and it performs about 45% of the lung activity. The reason for that, of course, is our heart is displaced to the left, and it takes up some of the room that the left lung cannot occupy. So let's look a little bit more now where the rubber hits the road, and that is the alveoli, right, which are tiny air sacs. It's at the very end of our respiratory tree, and they're arranged in clusters throughout the lungs. They are the functional unit of the respiratory system, whose purpose is to exchange oxygen and carbon dioxide to and from the bloodstream. And there's about 300 million alveolar in our lungs. And you can see there on the right, unoxygenated or desaturated blood comes in to the capillary that's up against the air sac, the alveoli. It releases its carbon dioxide, and then it gains oxygen. And as it leaves as red or oxygenated and saturated blood, right? So here's a pulmonary arteriogram, pretty fascinating one that I found, and really gives you some idea, if you've never seen one, how incredibly vast the network of blood vessels is to our pulmonary lungs, to our pulmonary anatomy. So let's talk about pulmonary physiology. Go ahead, Joe. So the major function of the lungs is gas exchange. Pulmonary circulation supplies deoxygenated blood to the lungs, where red blood cells release carbon dioxide, pick up oxygen, and eventually that is sent to our tissues, right? Pulmonary blood flow ideally needs to match the ventilation for maximum gas exchange. In respiratory physiology, the ventilation to perfusion ratio, also known as the VQ ratio, is a ratio used to assess the efficiency and adequacy of the matching of these two variables, the ventilation and the perfusion. V for ventilation is the amount of air that reaches the alveoli, and Q, the perfusion, is the amount of blood that reaches the capillaries of those alveoli. So this VQ ratio is defined as the ratio of the amount of air reaching the alveoli per minute to the amount of blood reaching the alveoli per minute, and that gives us our ratio of these volumetric flow rates. So these two variables, V and Q, constitute the main determinants of the blood oxygen and carbon dioxide concentration in our blood. So, thus, leads us to a concept called ventilation-perfusion equality, or ventilation-perfusion mismatching, known as what I said, the VQ ratio. So now, ideally, the oxygen provided via our ventilation would saturate the blood 100%. Knowing that 1 liter of blood holds about 200 milliliters of oxygen and 1 liter of humidified air has about 200 milliliters of oxygen. Therefore, the ideal ventilation perfusion ratio would be 1.0 or 100% saturation. In actuality, the typical value is approximately 90 to 95% saturation. And all of you guys know that because when you put a pulse ox on someone's finger, it reads almost always between 90 and 95% in normal routine physiology, not being on oxygen. So let's look at this a little bit further now. So the principal factor affecting this VQ gradient between the upper and lower lobes of the lung is gravity. The apex of the lung is going to have a higher VQ ratio, meaning higher saturation, but the base of the lung is going to have a lower VQ mismatch, decreased saturation. When you're standing upright or sitting up in an upright position, gravity causes a greater amount of blood to travel to the lower lobes of the lung, and less of that blood travels to the upper lobes. So at the base of the lungs, blood perfusion is therefore greater than the ventilation that it's receiving, lowering the VQ ratio. This results in a lower saturation. In the upper lobes, however, blood perfusion is less than the ventilation. You actually have more ventilation than the amount of blood coming through. So you have a very high saturation in the upper lobes, and so their VQ ratio would be much higher there. So in the last sentence there, VQ ratios change according to position, orthostatic position versus prone position. When you're lying down, the same thing happens, unfortunately, but now a lot of the blood is to the posterior sides of your lungs and not to the anterior. So you almost always have this mismatch going on. And here's a paper in 2013 by Dr. Wang and his associates, Risk Factors for Pulmonary Complications Following Cardiac Surgery with Cardiopulmonary Bypass. So now that we've talked about the anatomy and physiology, what are some of the complexities that this pulmonary circulation poses to us as perfusionists? So they looked at evaluated risk factors for post-op pulmonary complications. They took 2,056 adult patients that underwent cardiac surgery with cardiopulmonary bypass, and they found there was a 7% or 143 other adult patients suffered from post-op pulmonary complications. And they revealed independent risk factors for post-op pulmonary complications, which included all those things I have listed there: old age, greater than 65, congestive heart failure, low pre-op PaO2, if you already have predisposed lung issues, cardiopulmonary bypass greater than 80 minutes, aortic procedures posed a higher risk, people with AKI, being a woman, smokers, people with diabetes mellitus, hypertension, of course, people with COPD, and then if you suffered any intra-op phrenic nerve injury, that also predisposed you to higher pulmonary complications post-bypass. So now let's talk about the bronchial circulation. It is a separate circulation from the pulmonary circulation. It's completely separate. It's complementary to the pulmonary circulation, however. But the bronchial circulation supplies fully oxygenated arterial blood to the lung tissues themselves, the parenchyma of the lung tissue. It supplies nutrients and oxygen, also carries away the waste products. It also perfuses the bronchi and the pleura to meet their nutritional requirements. So we have two circulations. We have the pulmonary circulation, which is the functional unit of the lung, oxygenating our blood. But then the bronchial circulation is perfusing the tissues of the lung, right? So if we go ahead, go back, Joe. So in the bronchial circulation, this is the steps that the blood goes through. If you look at the aorta diagram there, the bronchial arteries branch from the descending aorta just below, just past the left subclavian takeoff, really at the very beginning and the upper beginning of the descending aorta. You're going to have these tiny branch arteries that are the bronchial arterial branches. Now, I put that diagram there. You can have any combination of these. There's a lot of variations when you look at genetic differences of people. Sometimes people have two on one side and one on the other. Some people have two and two. Some people have an artery that bifurcates. But regardless, you have these arteries that come off at this point of the aorta, perfusing the lungs for the lung tissue of the bronchial circulation. So let's look at this now, is where it gets a little interesting. The lung tissue perfusion occurs, exchanging oxygen, carbon dioxide, nutrients, and waste between the blood and lung tissues And some of these bronchial, remember I said pulmonary alveolar capillaries, these are bronchial capillaries. Some of the bronchial capillary venules, right, as it leaves the capillary, merge into the pulmonary alveolar venules and subsequently empty into pulmonary veins. So you see the drawing there. You have your pulmonary alveolar capillary at the bottom, but your bronchial capillaries, the ones that are perfusing the tissue of the lungs, the venules empty themselves. Some of them merge into the venules of the pulmonary artery, depositing venous blood into the pulmonary vein, and it travels on its way back to the left atrium. Go ahead, Joe. That's number one. Number two, you actually have independent bronchial veins that lead from some of these bronchial capillaries. Not all of them merge with the alveolar capillary. Some of them have their own individual bronchial vein, but the bronchial veins of these empty right into the pulmonary vein also, which keeps sending deoxygenated blood back to the left atrium as well.
Hey, John, can I say something?
Sure.
How many times did you, John, or you, Mike, or Rodell, if he's in there, how many times doing a mitral valve through the left atrium, and we're getting flooded, we're just getting flooded, and can't figure out where it's coming from?
Right.
Yep, and we're going to touch on that a little bit. So there's one more perfusion structure to this bronchial circulation I want to show you there, Joe. Go ahead.
Next one.
Yeah, so, and as it turns out, so if you think about it now, you have this lung being perfused, and its venous deoxygenated blood is going into our oxygenated blood of the pulmonary veins, mixing with that and going back to the left atrium. Whoever you subscribe to as our maker must have been scratching his or her head saying, this is counterproductive. Why are we mixing deoxygenated blood with our oxygenated blood going back to the left atrium? That defeats the purpose of why this blood is coming back to the left atrium. So believe it or not, there is about 1/4 of the actual bronchial circulation has bronchial veins, but these bronchial veins lead over to our vena cava system as we would have expected it to do, and it actually dumps into the superior vena cava. So this is about 25%. And by the way, this can vary 5 or 10% with each individual person, but basically about 25% of the venous bronchial blood does go back to where we would have expected, which is the superior vena cava. And it basically gets there by running into the azygos veins and hemiazygos veins and going up the azygos system and emptying right there into the SVC. So it makes its way back to the venous side as we would have expected it to. So let's look at bronchial physiology. The bronchial arteries branch from descending aorta and carry oxygenated blood to the lungs. This leads to pulmonary capillaries, where there's exchange of oxygen, carbon dioxide, nutrients, and basically perfusing the tissue. It's 1/4 of this venous blood goes to the bronchial veins of the superior vena cava, and 3/4 of it is being routed to the pulmonary veins and onto the left atrium. This 3/4 bronchial circulation is effectively an arterial venous shunt. That's what's important to remember, right? It's going from the left side back into the left side. So what is the complexities for extracorporeal circulation, Joe? You basically touched on it there. And this is a paper back in 1997 talking about, some of the things that can happen with our bronchial vasculature. And it's interesting, the formation of new bronchial vessels, angiogenesis, occurs in a variety of chronic inflammatory, infectious, and ischemic pulmonary diseases. So in contrast to the pulmonary circulation, the bronchial circulation has a remarkable ability to proliferate. You're talking about some patients having more flow than others. Hypertrophy and angiogenesis of the bronchial circulation in response to a variety of stimuli, including chronic lung infections, pulmonary artery occlusion, lung tumors, and lung transplantation. So the bottom line, the bronchial blood flow has implications for extracorporeal circulation, as this persistent blood flow must be constantly vented or in some way accounted for as it enters the left atrium and causes visualization difficulties for the surgeon. So we all know that part. So here's a little surprise, Joe, that I did not put into the outline. This is a little surprise, and you guys can tell me at the end if you were surprised by this or not. So we talk about two separate circulations for the lungs. However, they're complementary. There's a complementary relationship between the bronchial and pulmonary circulation. Lung infarction occurs when an artery of the lung becomes blocked and part of the lung dies. But because of the dual blood supply to the lungs from both the bronchial circulation and the pulmonary circulation, this tissue is extremely resistant to infarction. Now, an occlusion of the bronchial circulation rarely causes an infarction, but it can occur in a pulmonary embolism because the pulmonary circulation is blocked and the bronchial circulation cannot fully compensate for it. So you can have a lung infarction. It is possible, but it's highly resistant to it. So this is the reason why. I haven't explained why that is, right? A unique characteristic feature of the pulmonary vasculature is the extensive system of something called supernumerary vessels. These vessels branch off at right angles from the arterioles, from the accompanying arterial vessels, and supply nearby respiratory tissue also. The functional significance of these vessels is to provide collateral flow to surrounding tissues if the bronchial vessels are ever occluded. So as it turns out, the pulmonary circulation also perfuses our lung tissue as well as the bronchial circulation. So here's some questions hopefully we can get some answers to. But we're just going to start with questions 1 and 2, and we'll get to the third one after the right ventricle talk. So knowing that all the blood enters the left atrium, comes directly from the pulmonary alveolar capillaries, why does the oxygen saturation in the left atrium never reach 100%? Go ahead. And the pulmonary circulation, there's actually two answers, right? The pulmonary circulation, due to that VQ mismatch, cannot produce 100% saturation. You have less than 100% saturation in the lower lobes especially. Blood perfusion in the lower lobes is greater than the ventilation, so the blood cannot be fully saturated, resulting in lower saturation. In the lower lobes, the saturation is only approximately 90%. That's one reason. 3/4 of the bronchial circulation is effectively an arterial venous shunt. So desaturated bronchial blood is being routed to the pulmonary veins and back into the left atrium. So these two factors, incomplete saturation of the pulmonary blood and the bronchial circulation depositing desaturated blood into the pulmonary veins, are the reasons why we cannot have 100% saturation in the left atrium. So, the question number 2, knowing that our blood circulation is one big circle and the right and left ventricles are in series with each other, why do the medical textbooks say right ventricular outflow is approximately equal to the left ventricular outflow? Go ahead. So, going back to the bronchial circulation, those bronchial veins that are leading into the pulmonary veins, and the two I showed you, one where they merge into the alveolar venules and one where bronchial veins hook directly into the pulmonary vein, this sends the bronchial venous blood back into the pulmonary veins and back into the left atrium, right? This, go ahead, Joe, this is basically taking arterial blood from the aorta, sending it to the tissue of the lungs, and instead of it going to the venous circulation, it comes back into the left atrium. And by the way, I say on the right there, the bronchial flow is approximately 1 to 3% of the total cardiac output. So this basically, and I put down there at the bottom, these two factors, the bronchial circulation is effectively an arterial venous shunt, and because the blood leaving the left ventricle is sent right back to itself via the left atrium, the left ventricular outflow, the cardiac output of the left side, must be 1 to 3% greater than that of the right ventricle. Go ahead.
More?
You got the clicker? Yeah, go ahead, Joe.
Oh, one more? I thought I did it. Okay.
Okay, so let's talk about the right ventricle.
Can I raise my hand?
I don't know, because you might have to hear this first. I don't know. What's your question?
So you didn't mention Thebesian veins.
I didn't mention the Thebesian veins, nope, but that is also true because that's affecting in the heart, right?
Yes, because that's also a right to left shunt.
Mm-hmm.
Effective right to left shunt, I think. Pretty sure. But I thought I'd add that in just to show that I'm smart. Go ahead.
here's something that we hardly ever hear also. Everybody says ejection fraction, left ventricular ejection fraction. In fact, you don't even have to say left ventricular. When somebody says, what's the person's EF, you automatically know they're talking about the left ventricle. Why does nobody ever talk about the right ventricular ejection fraction? In fact, what is the right ventricular ejection fraction? Do we just assume it's exactly the same as the left? Well, as it turns out, it is actually not. It's actually about 5% lower. So while normal left ventricular ejection fraction is about 55 to 60%, right ventricular ejection fraction is about 52 to 58%. So let's look at this a little closer. Echocardiography, by the way, is not a reliable way to look at right ventricular ejection fraction. A better way is through MRI. But when you do take an echocardiography, a 4-chamber view like on the left there, and if you look at it, the right ventricle appears smaller than the left ventricle. If you look at normal anatomy like on the right ventricle appears larger than the left ventricle. So it's very difficult to get a perfect side-by-side section of these two ventricles. And our impression, I think a lot of us have, is that the left ventricle is actually larger than the right. Well, do we really know that? Go ahead. So here are some numbers for you. And this is right down the middle, 75 or 80 kilogram man, healthy routine. And this can vary on either side of these numbers by 10, 15% at least. But this is for a healthy individual. You compare the right and left ventricle. The end diastolic volume of the right is about 145, but the end diastolic volume of the left is a little bit smaller, about 142. So as it turns out, the chamber size of the right ventricle is actually a little bit larger. The end systolic volume, after it ejects on the right ventricle, is about 51, and the left ventricle is about 47. So your stroke volumes are pretty similar. Your stroke volume on the right ventricle is 94 milliliters, the left ventricle being 95. So the ejection fraction here would be a right ventricular ejection fraction of 65% with a left ventricular ejection fraction of 67%. So at a heart rate of 75 beats per minute, and this is where it gets interesting. If you did a Swan-Ganz on that patient that's seeing here on the diagram, you shot a cardiac output with those numbers that I have there, your cardiac output would come back at 7.05 liters per minute, 7,050 cc's per minute. That would mean that the left ventricular output is 7.125 liters per minute, okay? Which means the right ventricular output is 120 cc's less per minute, and that is because of the bronchial circulation. So why is this important? Why do we care? This is one reason why. There may be others. In the cases of if you're ever managing an RVAD, LVAD, or a BiVAD, due to the bronchial circulation, one must always account for the left ventricular output being 2 to 3% greater than the right ventricular output, right? If you have a BiVAD going, you have two separate pumps, an RVAD and an LVAD. One thing we always say at our institution is one must never overflow the right side in cases of an RVAD or BiVAD, because the left should always be flowing a little bit more. It's very scary to see if the right side is flowing the same or more because of what we just said. The left side should always be flowing slightly higher. And if you don't have that, you could cause flash pulmonary edema, which we have seen. All right, guys. So what did you think about all that? Thank you so much for listening.
Very good. I thought it was great. Mm-hmm. I enjoyed it a lot.
Did you know all that?
Did I know it? Maybe not the stuff on the RV output, but it makes sense to me. Mm-hmm. I never really considered it. But I do know, I have heard that too when we're doing BiVADs. And I remember back in the old days where we would have two Biomedicus pumps, right, or we'd be using that old Travenol thing that they used to have. Mm-hmm. I remember that. Right. And that was with roller pumps. And you had to make sure that you adjusted that. The left side was just slightly higher mm-hmm. than the right side, and you'd always be it was very difficult because you'd collapse the right side and then you'd have to slow the other one down a little bit, right, let it all catch up. It was, they were very difficult to run. Somebody's calling in. Jeff Campbell says, always run the LVAD slightly higher than the RVAD RVAD, which is what you said, also because of pulmonary edema. Right, that is a problem because you'll back the whole system up.
Right.
You know. And hello, you're on the air? Oh, they hung up?
No, that's somebody's phone. Yours.
Oh, it's not mine. Mine's on mute. I don't know
I can
who's
tell you
phone.
a couple things that happens too, Joe, with the BIVAD. We had LVAD, the LVAD pump was going bad. It was rattling and it was getting very hot. And so we were going to have to change out just the LVAD while we still had the RVAD running. Don't ever just turn off that LVAD while you're changing it out and leave that RVAD running, right?
Yeah, absolutely.
You can call flash pulmonary edema within 30 seconds.
Yes.
And it'll pouring out of the endotracheal tube in no time.
And it looks bad. It comes fast. I've seen fountains. So it's really frightening to see. Rodell, you have any experience with that? I don't know if you do or not.
Actually, I don't. But no, I understand the physiology behind it. I didn't realize the percentages, but it makes total sense.
Yeah, I mean John. This was a very interesting, unusual talk because I think you're 100% right. We really don't. Again, it's like I've said this before about the kidneys. Well, I say it, but I think that the kidneys are an underappreciated organ. I don't think we really consider, for example, what the neurologic consequences are of what we do every day for our jobs because we don't see the patients later. And I think we should be doing TCD on everyone. I think so. We don't care for the kidneys enough. But unless you have a patient who has right ventricular failure, and it's a nightmare, they're very hard patients to manage. We underappreciate the right ventricle too, I think. We think about the left ventricle and the aorta and the arterial system, and we sometimes become a little, we take the right ventricle for granted. I think we do.
Yeah, we do.
Well,
John?
a couple things that I did not know when I was researching this that surprised me was I didn't realize that not all of the bronchial circulation comes back into the left atrium. I didn't realize there was a venous route where about 25% or so ends up going over to our venous
Well,
system.
actually, I didn't know that either.
Yeah,
I didn't know that. I thought all
And-
bronchial return dumped into the left atrium.
I did too. I did too.
And when somebody, I heard somebody say not too long ago, which sparked my interest, right ventricular ejection fraction. I thought to myself, before I just say it's the same as the left, do I really know that? And when I dug into it, it turns out your right ventricle, and then I said to myself, how do we even know the right ventricle is the same volume size? Because if it's a different volume size, and the thickness of the muscle is different, so maybe the chamber size is larger, maybe it's smaller. If you look at it on a 4-chamber echo, it looks smaller, but that you can't go by that because it depends the angle. And it turns out that it's a little bit larger, so its ejection fraction can be a little smaller, right, percentage-wise. And then, of course, you have the bronchial circulation that the left side has to pump a little more. So between the two, they're not exactly the same.
Yeah, that makes a lot of sense to me. It makes me wonder, though, because I've got Rodell, Jeff Campbell says hello, and thanks for teaching him so well at OSU, or when he was at OSU, and I guess did his rotation up there. So I wanted to pass that on to you. But it makes me wonder, what happens, and thank goodness that the bronchial, the lung has two methods for being perfused, because if you do a big thoracoabdominal, or you do you do one of those TVARs, and you put a big stent graft in from just distal to the left subclavian, down around, to the descending thoracic, you're knocking all of that off. Right. So those people effectively lose their bronchial circulation if that's what the takeoff is. And I wonder if that, I'm assuming, and I'd have to ask somebody, if there's anything they have to look for. But it's a small amount, so I guess it compensates somehow, but there is no pulmonary infarct because you have two methods. Right. But I would assume that patient with a PE, even smaller PEs, would be much more susceptible to small pulmonary infarcts.
Right, right.
What do you think, John? Does that make sense?
I did not know also, the third thing I did not know was that there was any contribution of tissue perfusion from the pulmonary circulation. I did not know that. I thought that that pulmonary circulation was solely doing oxygen and carbon dioxide, exchange, and the bronchial circulation was doing tissue perfusion. I did not know the pulmonary circulation actually is a redundant tissue perfusion for the lungs as well. I did not know that.
I did, but I thought it was primary. That the bronchial circulation in comparison is that the pulmonary circulation is everything, or just the normal pulmonary arterial system going to the venous system. I believe that's primary, and then your bronchial circulation is the redundant portion of it.
Actually, you're actually correct, and this is how you don't either you can have a pulmonary infarct or you cannot. If you have a large enough PE, pulmonary embolus, you can have a pulmonary infarct. However, if you have a very large bronchial obstruction, you will not have a lung infarct, and that is because of what you just said. As it turns out, the pulmonary circulation is the primary tissue perfusion for the lungs, and the bronchial is a secondary. So you can have a pretty big occlusion of your bronchial circulation and not lose any lung tissue. However, if you have a very large pulmonary embolism and the bronchial circulation is just cannot is overwhelmed because it cannot perfuse enough of the tissue, you will have a pulmonary infarct, but it's actually caused from a large pulmonary embolus.
Yeah, I see that, and that makes a lot of sense. So another listener says that we should discuss the consequences of this return during ECC, ECMO, extracorporeal circulation. I think we kind of did, we did a little bit, but I mean, if you're doing a valve, if you're doing heart surgery and you have the heart open and they are getting flooded, I mean, that's the only maneuver we really have is to turn the flow down and let the pressure run a little lower, which may be not so beneficial for everything else, but it goes back to what I've discussed in previous programs, which is and I saw that, Jeff, previous programs that we have to keep the patient alive. There are things we do to reduce the metabolic need. We run at the very tightest limits of perfusion pressures because the operation has to get done. And Jeff brought up the need for LV venting, of course, absolutely. Sometimes PA vents can help with that, for the volume return to the left atrium. Mitral valve docs sometimes complain of venting during ECMO need for, and also need for ejection. So those are all very good points, Jeff. I agree with all of that. So Rodell taught you well, or you learned it later, one or the other. I'm not sure. But yeah, I saw you laugh there. But yeah, I think that these are things we need to be thinking about and considering, because I know some younger perfusionists, and when I was younger in my career too, that the surgeon's complaining, I can't see, I'm getting flooded, what's wrong with my return? And I think that those patients had just a very hyper-developed, secondary to their diseases, John, which you were saying with all the collaterals, just a hyper-developed bronchial direct, circulation and direct intracavitary return of that, plus, maybe even more, a more robust Thebesian venous system, which is also dumping directly into there. And it's tough. It's very hard to work with that.
Right, and if you remember, back when we went through school and everything like that a long time ago.
It used to be more common.
The anatomy was not as big a part of your curriculum as the actual clinical portion of the stuff that you did downstairs. And a lot of times when we'd hear these situations like, I'm drowning up here, what, turn up the floppy, give me a PA vent. Now it all makes sense why you had to do those things. But as a student we didn't know where that blood was coming from. It was very hard to figure out why. We knew it was there, it was causing problems. We knew we had to get rid of it so they could do the surgery. But actually knowing, much more about it now, it all makes sense. All makes sense.
Yeah, and I think too, that's very good. You bring up a very good point. And I think too that's sort of a difference, John. I know kind of where you come from, and I think that, and I really feel that I was very blessed getting into this business when I did, because we had to scrub, we had to first assist, we had to, there were so many things we did, and and we learned this stuff because we were, I was still in the, you have to think about this. I started my training, now you very close behind, not very far behind, plus you had nursing school ahead of me. I was a corpsman, but still very, I think, similar. But from the first successful use of the heart-lung machine to my first day of training, was only 24 years. Yeah. 24 years. When you think about heart surgery is now, how old from the first successful? 53 to now, that's 50 and 17, 67 years.
Right.
67 years, yeah.
Right.
So you start back that early, and we were all still learning these things. Even the people that were teaching me were still, we were all still learning things. And I think it was a really good environment to be in. Now it's become, very, very computerized, if you will. It's not quite as hands-on as it used to be. It's different.
Yeah, I was going to ask Rodell, since we graduated from the same school, be back in 82, it was interesting that back then, when we went through the school, we had a one-year clinical program, and we learned didactic along with that in conjunction with the clinical. We would come in, do the first case, go to class, come back and do the last remaining 2 or 3 cases for the day. And that's where it was. I was there the year we did 5,000 open hearts.
Wow.
At St. Luke's, and we pumped a lot of cases. We certainly did, but it was interesting, and I wanted to ask Ro, on my diploma, it's a diploma program back then. There's no Bachelor of Science or anything. And it says...
Well, I have a diploma.
It says...
same thing.
Oh, yeah.
From my school.
But it says cardiovascular assistant. It doesn't even say perfusionist on my diploma. And that's because we learned how to harvest the leg veins. We would cannulate with the surgeons. We would do post-op. We would, extract chest tubes and stuff like that. Did yours change from...
Quite a bit, actually. We did the same thing. We had the didactic along with the clinical at the same time because it is a year program. We didn't do the hands-on things like pulling chest tubes or taking vein or cannulating or anything like that. That was actually more the didactic portion of it. You can go up at the head of the table and actually watch it. But that was pretty much it. We're very little scrubbing in because of all the fellows and the younger physicians coming in.
Yeah, it was interesting. Not too many people can say they had a chance to cannulate a patient with Dr. Cooley, and I thought that was pretty much the highlight of my career right there. So I'll never forget that one. But that's what we and all of associates too. So it was really, really interesting.
That is, he was a gem, wasn't he? He was a gem. Can I tell a Cooley story? I know it's not relevant, to the topic at hand, but I got to tell the story. It's a Cooley story. Okay, so in 1984, I was at a meeting in Philadelphia, and Dr. Cooley was the guest speaker. And you could meet him. They had like a line that you could go and shake his hand and say hello. And of course, it was all heart surgeons, and there were a few of my perfusion friends that were there, and they were all crowding like they didn't care about us, and I wasn't going to be denied.
Yeah.
So I nudged my way through the mass of people and got up to him and sort of startled the people that were like there, because I was nudging, and I was like, Dr. Cooley, I'm Joe Bosch. I wanted to shake your hand, And he's like, and he was very gracious. He was very kind. I was a young kid, I looked like, and he was very, very nice. Now he didn't remember that years later, but back around 2000 and I don't know if it was 2012 maybe, when he won the Crystal Heart Award with us at the New Orleans conference, and he couldn't travel to the conference. He couldn't go. He was in that little motorized chair at the time, and didn't feel comfortable traveling. And so we went to his office to do the award ceremony, and he had his own film crew there. Okay, they had their own stuff, right? And so we're doing it, and I had Dr. DeWitt and Dr. Matoyer were both there, because they were both of his last fellows that actually had a chance to operate with him. Okay, because after that, the fellows didn't get to operate because Dr. Cooley stopped operating completely. He'd go in the OR, but they actually got to physically operate with him, right? And so when they were finished with what I had asked them to say, Dr. Cooley looked over at me and he said, Joe, was that what you needed or what you wanted? And I said, well, no, Dr. Cooley, not exactly. But I was trying to figure out, how am I going to say this and not, be, how am I going to say this politically sensitive? And I was like, not exactly. I would have liked to have, these are the kind of things I want to say. And I sort of gave them the kind of the script, but they kind of got a little bit lost in it. And he said, I said, it'd be good if they could do it again. And he thought about it and he said, no, Joe, I don't think so. I think, why don't you come stand behind me and I want you to do it. And I was like, well, Dr. Cooley, because there's Matoyer and DeWitt both there, and I was like, well, no, Dr. Cooley, that's okay. They can do it. I could just coach them through it a little bit. And he said, no, Joe, you don't understand. I'm telling you to come back here and I want you to do it. So I was like, oh, I think that's not I understand those kinds of requests. I got this. So I got up, I went behind him. Dude, my mouth was dry. I swear I was nervous as a cat on a hot tin roof. I was just like, I can't believe this is happening. So the guy with the camera, he's like, okay, ready? And he even has one of those things. I mean, this is a big production for those guys. And the light, like this light here, the red light came on, they were filming. So I went on my spiel. Now this is the highlight of my career. There's nothing else can top this. And Matoyer was there, so I have proof. DeWitt was there. There's proof of this, their recollection, because they were there. And after I finished with what they were supposed to say, Dr. Cooley leaned around like this and looked at me and said, I do believe you need to run for president. And I was like, that's it. I don't need to do, I can end my career today and I will have had a great career. Okay, so we'll go on and get to my slides now, but that's my Cooley story. And he was a gem. He was just such a nice person. And I had a chance to visit with him several times down here at Texas Heart. And he was always very gracious. He always made you feel like you were the most important person in the room. And I don't know anyone else like him. I don't know anyone else that can be him.
No.
Yeah. Do any of you guys? I don't know.
No, and Mike, I must have missed you by just a few years. I arrived at Texas Heart in 1985 to 87.
December of 82, and then I was gone by November of 83.
And you're right, we did a month of anesthesia rotation, we did a month of surgery rotation, we did a month of cardiology with the cath lab guys.
Right.
And I want to say there was a fourth one. I think it was isolated limb perfusion, but I never made it over there.
I think at that point it was the quote circulatory support team. We went with them to put in balloon pumps. We went down to the animal laboratory.
Oh, yes, the animal lab,
do things like that.
I did do that.
Yeah.
Yeah. So, okay, so I know, and that's the difference in the type of training. That
Yeah.
kind of training cannot be duplicated.
Yeah.
Going and seeing all, especially when you're young in this profession, young in your career, your brain is like a sponge. You're still so excited, you know, that, oh my God, I get to come here and do this. I mean, this is, you know, and it's so, it just makes the whole experience, and one that you'll never forget, you know, because it was intense and it was serious, and they would have no problem cutting you from the program if you weren't going to cut it.
That's for sure.
They didn't play around back then.
No, they didn't.
You know, at all. Now, I mean, now they got rights.
Yeah.
We didn't have any rights. You know, what rights did we have? You're on call for the entire time of your training. There was no day off. What do you mean there's a holiday, your birthday? I don't care. Your wife's having a baby and it's yours? Okay. Good. What are you going to name it? You got a case to do.
Yeah.
You know?
Oh, yeah.
It's a totally different philosophy back then.
It was.
And, you know, and I don't know that was right. It may have been a little over the top.
It's what it was.
But it made us who we are.
Yeah, it's what it was.
It makes you who you are. There's no question about it. All right, we're on to a philosophical discussion once again. So let's move on to my talk. My talk is going to be lighthearted. I want people to jump in. You can ask a question. I may ask you questions, whatever. We'll just kind of have some fun with this. So I'm going to do ECMO patient selection and then ECMO complications part 1. And then we'll take a break, and then John will come back and do his anticoagulation, and then I'll do part 2, okay? So I want to start this off with some key points. And that is, ECMO is a powerful tool, but there must be a destination. You got to have that. Indications and contraindications are by and large relative. Now, there are some absolutes, and we'll talk about those as I move forward, but by and large, they're judgment decisions. And if you're gonna do ECMO, call early. Calling early saves lives. Calling late portends usually a poorer outcome, and sometimes just a position of futility, if you will. So let me just move to this part here, some historical perspective, and I don't want to spend much time on it, but you know, between the 30s and 54, of course, Dr. Gibbon and his development of the heart-lung machine, and there were others involved, of course, many others who were working on the same project, but he gets the credit for it, and I think deservedly so. In the 50s, of course, Dr. DeWall, who was working on a membrane oxygenator, and I don't know if you all knew this or not, I don't want to spend too much time on it, but Dr. DeWall was one of the first, or the DeWall, bubble oxygenators ever made. And it was a very interesting device. But as a side note, it was Dr. DeWall who figured out that to deal with the foaming blood, you use this surfactant material, Dow Corning. It was made by Dow Corning at the time, Antifoam A. Exactly.
That's it.
Well, I actually, believe it or not, have a copy of a letter that Dr. Oh my gosh, his boss, Dr. I'm blanking on his name now. I'll think of it later. Sent to the president of Dow Corning and said, look, we're using this with success. We've tested it in animals with amounts much larger than we would need in humans, but we cannot seem to find any toxicity. Is there anything you can share with us about it? Now, this is silicon-based, okay? But they ended up using it for quite a long time. But actually, DeWall came up with this idea on his own. He thought of it independently as the solution to managing the foaming caused by the bubbling. And then later, of course, this is up at Mayo, later, of course, Dr. Cooley, who went up there to see some of these operations, came back and made his famous coffee pot bubble oxygenator from the coffee pot percolator he got from the what do you call that, the restaurant supply store. And that was that was the second bubble oxygenator. So very interesting story with Dr. Wolf. He was working on a membrane oxygenator for the purpose of longer term support, even back then, which is really amazing. In 71, it was the first reportable successful use of ECMO, and it was published in the New England Journal. It had to do with an adult patient with post-traumatic respiratory failure. They basically went into ARDS. 1972 was the first successful pediatric use. In 75, between 75 and 89, the randomized controlled trial that was done by Zappal, or Zappal, however you pronounce that name, sort of was the prevailing belief, and it was a negative trial. So in that trial, they concluded that there was really no benefit, survival benefit, with ECMO for either circulatory support or pulmonary support. So it was a negative trial, and that was published in JAMA and in 1979. In 1975, Dr. Bartlett, of course, had the case Esperanza, and the story of Esperanza, if you will, I'm going to go ahead and let you read it. I'll just go ahead and flip this, but you can read it. But she had infantile respiratory distress syndrome. Her mother immigrated here across the border, by walking. She was pregnant, had the baby, aspirated a lot of meconium, went into IRDS, and he treated that patient successfully, and thus the nurses named the baby Esperanza, meaning hope in Spanish, of course. And at that point in time, Dr. Bartlett, who was a thoracic surgeon, embarked on what is now the body of knowledge for ECMO, and of course he's the founder of ELSO. So I think that's very important. In the 1990s, and I'll go back to that slide, or you can look at it later and freeze the screen, we started seeing neonatal and pediatric ECLS centers. ECMO really was thought still at that time to be appropriate for the younger population, not so much for the older. In fact, even as late as the mid-90s, our results with ECMO were still pretty poor.
Dismal.
And a lot of that, I believe, was because of timing and also selection. So both. And there was a level of disgust with everybody. We use this on dyes. And so you start losing confidence in the tool because it wasn't really being used with the right patients, nor was it being used soon enough. And I think I believe that was a big part of the problem. In 2000, however, that started to change, and you started seeing adult ACLS or ECLS centers begin. And then in 2009 was the CESAR trial, which many people I know dispute the findings of the CESAR trial. They criticize the study design. I get all of that. But it was, I think, a pretty clear, in my view, I think it was a good trial, and I think it showed a clear survival benefit with VV ECMO, particularly in ARDS. And so from then on, we have seen an explosion of ECMO centers, an explosion of ECMO use, and we have seen, concurrent with that, an incredible amount of patients who have survived that would not have survived. Their vent settings and their gases and their oxygenation was essentially looking at that patient. This is going to be this is 100% mortal situation. This patient is not going to survive. And then use ECMO. And I've seen people who were in that position walk out of the hospital. In fact, we just saw one.
Yes, we did.
Very recently,
Yes,
who
we
was a
did.
police officer, who's going to come to the studio, by the way.
Is he really?
He is, and he's going to talk about his case. He has agreed to come here and sit down and talk about how all of what happened to him happened with the COVID. So it was he is the first COVID patient treated with ECMO in the entire greater Houston area, including the medical center. Right. So big circle around Houston, actually in the state of Texas, compared to anywhere. So he was the first to be treated with ECMO, and he's going to come here and tell us the story. He walked out of the hospital, is perfectly fine, and feels much better, and is grateful for all of the life-saving measures that we all took. But he was sick.
He was very sick.
He was not going to survive.
No.
So here again is the story of Esperanza. I didn't mean to just glaze over it early because it is a great story, but I'll leave it to you to read. You can freeze the screen later and come back to it and read it, but it's a very nice story. It's meaningful, and it's one of the reasons why we all do what we do. Things like this. You go back, do you remember Dr. Bailey? Len Bailey, Dr. Baby Faye? Mm-hmm. He passed.
Oh, he did?
He passed. His wife passed, and then he passed a week later, or 2 weeks later. It was very sad. I mean, we lost somebody who was, both him and his wife were beautiful people. Mm-hmm. But Dr. Robachek passed too. We've lost 75% of our Crystal Heart Award recipients, from the conference.
Yeah. It's amazing.
Yeah, Dr. Robachek said he was the best. He was one of the best Crystal Heart recipient speeches I've ever heard. He got up there, and of course he's Hungarian. He fought the Germans in the resistance. This dude was I could say it. I think I could use this word. He was badass. Mm-hmm. He was, and he was gruff. I hear you talk like this, Joe. What are you doing, Joe? Yeah. Why don't you know that, Joe? And he gets up to accept the award. The ceremony happens, and he's going to give his speech, and he says, "Well, I've come to realize you become very awardable when you get old." And it's like, what? He doesn't have to say anything else. It was over. So he was an incredible human being, but he recently passed, and I feel horrible about that. Dr. Badia trained under him.
I think I remember part of it. Yeah.
He did.
Yeah.
He did.
I remember that.
He did.
Yeah.
He was something else. In fact, when the AIDS epidemic started, Dr. Robachek, how I learned about Dr. Robachek was from back then. It was like 1987 or 88. And I read an article that he wrote. And it was basically how healthcare professionals that are in surgery, he was a heart surgeon, of course, too, but how you should manage a potential like needle stick or puncture of an infected needle, or an uncertain whether it's an infected needle. Mm-hmm. And he said you take a 10 cc syringe filled with betadine, and if you get stuck, for example, in your finger, he's calculated out, and I'd have to go back and look at it, but there is a point of time, from the point you get the inoculation, that whatever you are inoculated with virally is going to stay local for a period of time. Now, it's not a lot of time, but it's enough time. Mm-hmm. And if you take the syringe with the lidocaine and you inject it into the site and infiltrate it, you will not end up getting an HIV infection. It'll kill the virus before it has had a chance to get into your system, get away from the local area, and get into your system and proliferate. And so at first I was like, that sounds painful. But then you think, okay, well, it's that or dead, so that makes sense. So for years, I kept a 10 cc syringe of betadine on my pump with an 18 gauge needle. I did. I figured I would do it if I had to. Because we did cases that were HIV positive.
Probably more than we knew.
Probably that too, absolutely. Okay, so general overview. ECMO is a technique that involves obviously oxygenating blood outside of the body and provides pulmonary, circulatory, or both full cardiopulmonary support in patients with severe cardiac and or respiratory failure. There's two major modalities, veno-arterial and veno-venous. identified frequently as VA or VV, and as John Ingram taught us the other day, where the dash is where the oxygenator is. So when you get into these real fancy systems and you need to describe it,
Right.
you just have to remember, John, I think I got this right, the dash goes where the oxygenator is. Is that right, John?
That's exactly right. And
Good.
on the,
See,
on the left side is all your blood coming in, and on the right side is all your blood going back.
So it's access, oxygenator, return. The dash is the oxygenator. So see, I do pay attention. ECMO has to have a destination. We mentioned this. And those destinations are either a bridge to transplant surgery, a bridge to recovery, or a bridge to decision, because sometimes those happen. The patient gets put on ECMO, VA ECMO, they need a heart transplant, or they put on VV ECMO, they need a lung transplant, or they're going to get a permanent VAD, or whatever it might be. But there's some surgical procedure we need to just bridge them to get them there. Then there's, of course, we're just going to keep them on this until they recover, if they do. And then, of course, there's those that we put it in. We're uncertain about a variety of things. It might be an unwitnessed arrest, but they put them on ECMO anyway, which you probably shouldn't, but they're young, and you have to make these judgment calls. And when they're very young, a 19-year-old who, and remember the case we had at, I don't want to say the name of the hospital, but at that hospital where I kind of first started, and it was that 19-year-old who they found her in her college class, and she had collapsed, and but no one noticed it. Nobody really could say how long it had been, and we put her on VA ECMO, and she didn't survive, and she was neurologically gone, but had an anoxic brain injury, but or an anoxic brain death. But you know, who's going to say no? She got on. She got put on, and I can understand that. But once it was recognized, then you make that decision, and that's what bridge to decision is.
Right.
You know, really what it means. Let's see. Did I skip one, or did I just mess up? Oh, there you go. Okay, so I messed my slides up again. Can you guys pay attention to my slides? I mess them up all the time. Okay, so. Patient selection, indications for use, okay? Acute reversible cardiac or pulmonary failure when the risk of dying from the condition is greater than the potential risks of ECMO, because ECMO is not without risks. It is a rather invasive thing to do to people. It's not like dialysis. It's not like just a big IV. For all of you folks out there watching that may not be ECMO experts for some reason, those that are understand where I'm coming from here. This is not a simple, easy, uncomplicated, low-risk procedure. We've made it that way, like heart surgery. Heart surgery used to have a 70% mortality rate, and now for a routine CABG, it's under 1%. Maybe, you know, it's less than 1%, but maybe not, maybe as high as 3%, depending on your other risks, your other comorbidities. But it's very, very low. ECMO is very similar, but it's not without risk, and that's something that you have to be very careful of. It's used in neonates, pediatrics, and adults. I don't do neonates. I don't do pediatrics. My focus is going to be on adults. I'd love to find some neonatal and pediatric perfusionists who could actually address this. It's not my field of expertise, but I've always wanted to do more with those guys, but it's very hard to get them to come. Each center develops institutional guidelines for ECMO use, including indications and contraindications. So each center that is going to, each hospital that provides ECMO as a therapeutic modality can sit down, look at the ELSO recommended guidelines, but they can make their own. And there are a variety of standards that you have to take into consideration. There's international standards, there's national standards, but there's also local standards. And you have to, work with what you have. You don't have to directly follow ELSO standards. You can vary from them so long as it comports with a community standard of where you are. So you can't be way out and over here, way out over there. There's a standard of care if you're going to provide this as a therapeutic modality. Your inclusion-exclusion criteria have to be both reasonable to other people of like education, but also they have to be clear, right. And that's very important. Did I skip a slide again? Did I not do that? Okay, there. All right, so there's that slide. Okay. Do me a favor. If I don't switch the slide, yell at me. Okay. So VA ECMO patient selection. You have the indications. You have the contraindications. I'm talking about VA now. There are relative contraindications, and there are absolute contraindications. And I'm going to go through all of this, as we move forward here with this. So first, let's look at the potential indications: failure to wean, or post-cardiotomy syndrome, drug overdose with profound cardiac depression, myocarditis, early graft failure, so patients post-op in the ICU, acute heart failure for a variety of reasons, and now you're going to put them on bridge to decision, especially if it's idiopathic. You don't know what's wrong with them. They're just in heart failure, and then you realize you can or cannot do something for them, and then decisions get made. Pulmonary embolism, cardiac or major vessel trauma, pulmonary hemorrhage, pulmonary trauma, acute anaphylaxis, peripartum cardiomyopathy, something that can last, from the last month of pregnancy all the way to 3 months after pregnancy.
We did one of those.
And yes, absolutely. We just recently did, absolutely. And of course, sepsis. Relative contraindications, and these are the same for both VV or VA, but I didn't highlight the ventilation, I highlighted the others. Prolonged CPR greater than 45 minutes. That is a relative contraindication because you could have somebody with some kind of refractory VTAC that is young, viable. It's an electrophysiologic problem,
right.
And so you're not going to deny that person ECMO because you've been doing CPR for 46 minutes. So these are judgment decisions, okay? But it's a guide. Major pharmacologic immunosuppression is an enormous problem, and for VA ECMO, that is a big problem. If they have if their white count is under 400 or less than 400, I mean, it's not going to work. You have to consider what you're looking at.
Right.
If the patient's condition is really futile, you should not put that patient on ECMO. You really shouldn't. But that flip side of that is when you don't know and they're young or they are still, otherwise a healthy person who's lived that is living a very full life. Got to do everything you can.
Right. It's
the decision part that's hard, and that's ethical, and we're not going to get into that today, but it's another conversation. We've had it before with Dr. Samir. Coagulopathies, that's a relative contraindication because they're going to bleed, and they're going to have a lot of bleeds. Irreversible multi-organ system failure, that's chronic. Advanced age greater than 70. That's iffy too. I know a lot of 70-year-olds that can whip a 40-year-old's butt sometimes. So again, I think you have to look at not the age, you have to look at the total condition of the patient. So absolute contraindications, this is, you don't put it in. They have a non-recoverable heart function and not a candidate for any other therapy. When they are in complete heart failure and they have no other option and they are not recoverable, so bridge to recovery is no longer an option, it is a direct contraindication. If they're non-recoverable respiratory disease and not candidate for transplant. So if their respiratory disease or their heart disease is an irreversible problem and not a candidate for some surgical intervention or mechanical, long-term mechanical device, they're not a candidate. And then Ebola, and it seems odd Ebola is sitting in there,
Yeah,
but there
right.
is a reason Ebola is there. This is ELSO's Ebola statement. And basically what it says is that the Ebola infection can cause hemorrhagic problems and a lot of multi-organ dysfunction problems. But along with that, it is so easily spread with bodily fluids that here you have a hemorrhagic condition that you are putting surgically, whether it's percutaneously or not, it's still surgically. You're putting tubes in, running it at high speeds through a device. So you have two issues. The hemorrhagic nature, which is probably going to result when you now anticoagulate them,
Right.
is they're going to bleed to death. And of course, you are putting the healthcare providers at tremendous risk. And so it is an ELSO position statement that patients with Ebola should not be treated with ECMO. I thought that was interesting.
It is.
Advantages of VA ECMO are that you rest both the heart and the lungs. The patient is protected from cardiac arrest. If you have a patient on VA ECMO and they go into VTAC or VFib, other than wanting to make sure that the ventricle does not distend and blow up, which is why you may do some compressions, you don't have to run in there and hit the code button and drag in the code cart and go crazy.
Right.
They are supported fully. In fact, it may even help
Probably
some
be
patients
better.
if they have dual circulation, right?
Right.
So anyway, so you're protected from cardiac arrest. You have the potential for full support, and I say potential for obvious reasons, of 100% depending on the flow. If you have good venous return, you're going to have good flow. Now, I will tell you, on the VA ECMOs that I have done historically, where I was unable to capture all of their circulation, I will tell everyone there's two ways to skin the cat, right? You can add sometimes a second outflow, but really the best thing to do is to add another access. It's almost, I would say, ineffective if you don't want the heart to eject and you're on VA ECMO, adding another return line is not the right, it may seem for some people intuitive because I've seen people do it, but it makes no sense whatsoever. You want another access. Now, John, you do a lot more ECMO than I do. Do you agree with that or disagree with that?
You're talking about FEM VA ECMO?
Yes.
Well, there is two approaches you could take. One is to move that femoral arterial cannula up to a right axillary arterial perfusion, and now you've eliminated the problems to a large extent, provided you could flow enough.
Well, I'm not talking about north-south syndrome. I'm just talking about having enough flow.
Well, having enough flow is almost always about adding a cannula, right?
But
or
access, not a return cannula, an access cannula.
Well, sometimes you have too small of a return cannula. We have patients shipped in with a 15 French femoral artery cannula on a very big guy, and we cannot flow. Our pressures are 350, 400. So, but rarely, but most of the time, yes, you're usually worried about increasing your venous drainage out of the patient so you can flow more.
And you had the unique, I think, experience. I think we did too, Rodell. You may have to, or you may know, both of you guys. You had two entire ECMO systems, right? Two ECMO pumps.
Yes.
With two complete ECMO circuits. I know Mike did that. Rodell,
Right.
you did it. John, you did it too, didn't you?
Yeah, we've done it twice, and it involves 4 different venous cannulas.
Yeah.
And you can do a fem venous, and then you can do a right IJ, usually it's 3 cannulas, but technically one of them is a dual cannula
Yeah.
when you do like an Avalon or Crescent
what
in the
we
right
did.
IJ, and you have 2 femoral venous cannulas. And one ECMO unit may not be able to flow enough to oxygenate all that, so you have to split it into 2. That's what's happened a couple times.
Very good, very good. And VA ECMO is also easier for volume management than VV. So we're comparing VA to VV. So the advantages are you have easier volume management because you can turn your flow up. You need to empty the right side, you turn your flow up. But I don't think that that's, I think you can still become fluid overloaded certainly very easily either way, and frequently are, right? It's pretty rare that we end up desiccated, fluid depleted when we do ECMOs. Most ECMOs we do, they end up fluid overloaded, and we have to manage that.
Right.
Very hard. So disadvantages of VA ECMO: potentially less pulsatile,
Right.
requires arterial cannulation. So it's a second cannula from if you use a single cannula technique for VV, but you're going into the arterial system. That is a very different thing than being in the venous system.
Yep.
Now you're raising the stakes. You're making this a little bit more risky. More problems can occur. You can have more bleeding because it's the arterial system. You can have distal perfusion issues, which we'll talk about. You can have retrograde dissection. There's a lot of things that can happen when you're in. You can have, and I've seen it, perforation where you go retroperitoneal with the cannula and you go on pump, and the pump run is really short because all the blood is now in the retroperitoneum. So we've seen all of these things. As I said from the very beginning of this, I don't ever want to come across with being cavalier about the use of ECMO. It's a serious, very risky, though we've made it very safe, life-saving, when used properly, tool. But it's not something people willy-nilly should be doing. You got to be trained. You got to know what you're doing. Whether you're the cannulator or you're the ECMO operator, whatever it may be, or managing the patient, the intensivist, you got to know what you're doing. Another disadvantage is coronary blood flow, and that is mostly when you have dual circulation. So your coronary blood flow is not necessarily interrupted, it's just hypoxic.
Right.
You basically get coronary ischemia secondary to Harlequin syndrome, dual circulation, north-south syndrome, whatever you want to call it. VV ECMO physiology is basically you're taking the blood from the right atrium, you're oxygenating it, and you're putting it back into the right atrium in some, form or fashion, cava, inferior, superior vena cava, whatever. A volume of blood that's removed is equal to return, so there is no net effect on hemodynamics because it is a closed loop system. You're taking venous blood from the superior inferior vena cava, putting it right back into the right atrium, 1 cc for 1 cc. So there's, as far as what the patient's volume status is, it doesn't change that at all, and you're also not providing any arterial systemic flow, so therefore you have no hemodynamic changes. The only hemodynamic changes you may see will be a result of improved oxygenation where the patient should get better. VV ECMO, there also, as a result of that, does not support perfusion. It supports it indirectly with oxygenation, but it does not support it directly. Only variable affected is the CO2 and O2 content of the blood, and O2 delivery, therefore, or one of the issues, is dependent on an adequate cardiac output. So doing VV ECMO on a failing heart is fine if the failing heart is because of hypoxia.
Right.
But if the heart doesn't recover, you may be oxygenating the blood better, but it doesn't mean you're delivering the tissue, that big important DO2 number. You're not delivering adequate tissue, blood oxygen to the tissue, perfusion to the tissue. So VV ECMO selection. ARDS, we're very familiar with that, severe pneumonia, severe hypoxemia, status asthmaticus, pulmonary contusion, airway obstruction, aspiration syndrome, smoke inhalation. How many aspiration pneumonias have we put on ECMO? A lot. Smoke inhalation, firefighters, things like that, or people that were in a house fire, severe air leak syndrome, and alveolar proteinosis. It is, by and large, with some exceptions, a single cannula technique, which makes it a little easier. It can go in the neck. You can sit these people up. You can put them on rotoprone beds. There's a lot of things you can do because of the single cannula dual lumen technique. You rely on the patient's own cardiac output for your pulsatilities. It's oxygenated blood directly to the lungs. So going to your point, John, you're helping the lungs, the lung tissue heal, because, and this is something that is a benefit of ECMO that is oftentimes not recognized or understood or thought of. And that is that when you have lung tissue that has been damaged and it is trying to heal, has ARDS, adding that oxygenation to the venous blood as it comes out of the RV out to the pulmonary circulation, which is your primary
since we just learned
lung perfusion
from John,
then having that pre-oxygenated is actually helpful to healing the lung. That and reducing your inspired FiO2 from the ventilator, because that is corrosive. And that's why you want high pulmonary, you want the oxygenation, not just for it's for the total body, but it's very important for lung healing as well. And sometimes I don't think people really consider that in their equation. And why I get a little bit exercised when I feel like they're wanting to wean too soon, because I feel like I want that kind of like your tissue, your heart, your lung, all your end organs. When you have an event happen, you've been hurt, the more oxygen you can get to that tissue, it's just been proven over and over and over and over again. That's how we heal. You're getting what it needs to the tissue. Perfusion matters. We're essential, as a matter of fact, just so you know. But you want that same thing for the lungs, and I really don't like it when sometimes they get a little over aggressive. In my view, I don't like to do that for that reason. And you potentially get more oxygenated blood to the coronaries. Okay, potentially reminding you of that. Okay, so because sometimes you're on VA ECMO, you don't have bad lungs at all. In which case, your lungs are going to do what you don't capture if you only need partial support. Like how many times we see we can't wean from bypass. You get down to 1.5 liters. They still look good, but then you try to come off. You come off, and they crap out. And you go back on, and then you try it again, and you do this and that with the drips, and you try it again. That patient doesn't need maximal support. And if they have good lungs and you keep them unloaded and keep their left-sided pressures also down so you don't back it up and get pulmonary edema, their lungs work fine. And that aortic oxygenation going to the coronaries and to the head is no problem. It's the patients who have their cardiac function is really bad. Unloading it makes it better, but you can only get to, say, to 3 liters, and then they really don't do well. So they're not going to come off pump, but their lungs are trashed, and you're cannulated fem-fem, not centrally cannulated, and their heart keeps beating, and there's deoxygenated blood going out. That's when it becomes a problem. And you got it. That's why central cannulation, for VA ECMO, post-cardiotomy syndrome, central cannulation is really the way to go. You shouldn't convert them to fem-fem.
Absolutely.
And the hole's already there, so why change it?
Oh,
Just tunnel the cannulas. You can do that. Some disadvantages of VV ECMO: it's not protective during cardiac arrest, so now when the patient codes, you do have to run in there and start pumping, okay? So now is the time to hit the alarm bells, drag the code card in there, and start doing full full resuscitation. You have to do that. It's more sensitive for volume management. So because you're basically zero balance. If the patient is fluid overloaded, there has to be some other way to get that fluid off. Of course, I'm a big CRRT advocate. It does not rest the heart in any way, not the right side, not the left side at all. It's not an RVAD. That's a totally different animal altogether. And of course, you have one of the biggest problems is recirculation, mixing or having efficiency of oxygenation. And of course, I think I have, let's see, where was I? What am I on here?
You've gone back to contraindications.
Relative contraindications. Okay, so the relative contraindications, and I highlighted mechanical ventilation at high settings for equal to or greater than 7 days. The data is pretty clear that once you get to day 7, where you have maximum ventilatory support with high pressures, high PEEP, low oxygenation, your survival curve drops very quickly and very steeply. Obviously, these other things are also relevant, but that's one that didn't exist for VA. But these other things still do exist. If you're doing CPR, even if you think it's just a lung issue, you've been doing CPR for 45 minutes, you have to consider that patient. If they're immunocompromised, you have to consider it. If they have major coagulopathies, irreversible multi-organ dysfunction syndrome, and obviously advanced age. What's absolute contraindications are non-recoverable heart functions, exactly the same. Won't even say it. The absolute contraindications for VV ECMO are the same as the absolute contraindications for VA ECMO. And this is really very simple. Is this patient survivable? A. Mm-hmm. Yes. Okay. We can survive this patient with ECMO. Notice, can we keep them alive with ECMO? If the answer is no, don't do it. If the answer is yes, okay, that's a maybe. Is what's wrong with them in any way correctable? If the answer is no, you shouldn't put the patient on ECMO. If the answer is yes or I don't know, you put the patient on ECMO. Once the patient's on ECMO and you find out it is not a fixable problem, then now you're at the decision point, and that's what bridge to decision actually means. I use this graph all the time. If you just look on the left side, you have on the top left, refractory hypoxemia with a Murray score 3 to 4. You follow the arrows down. If you are or are not in cardiogenic shock, and then depending on which those are, if you are without shock or vasodilatory shock, like vasoplegia, then follow that line down and it goes straight to veno-venous ECMO. Mm-hmm. If you are in cardiogenic shock, follow those lines down and you have to ask yourself 2 questions. It's one question with 2 possible answers. Is this due to hypoxemia or is this due to some other heart failure? If it's due to hypoxemia, again, you go to VV. If it is due to another heart failure, you go to veno-arterial or veno-arterial venous, which would be V-AV, okay, in this case. So with COVID, the world is coming to an end, and we have finished the first part of my thing. What else do I have to? I have to still do the. Where are we at time-wise? ECMO patient selection and complications. Okay, so I have 7 minutes to get through the complications. I think I can do that, and then we can take a short break. And here, as the slide says, the world is temporarily closed. But it's coming back. It's coming back, and that's another discussion we have to have. So ECMO complications for me are divided into two categories: common and manageable, and catastrophic. I'm going to only talk for this section about the common manageable ones. And there's not really that many. There's surgical site bleeding. There's cannulation site bleeding. A surgical site bleeding would be post-cardiotomy. You can't close the chest. You have a drape on it. They're bleeding. You can put a sucker in there and run it to the cell saver and get that blood back. We've done that before. But surgical site bleeding after surgery is not uncommon because you have to keep the patient anticoagulated, and they've usually been on pump a long time, and they've got all kinds of other coagulation derangements from just losing factors and other things. Cannulation site bleeding, that's obvious. Coagulation derangements, distal vessel ischemia, which we know how to fix. If you're femorally cannulated, you put a line in the SFA distally to the cannulation, then you can perfuse the foot and you feel it get nice and pink and warm when it was purple before and cold. Inadequate flow, north-south syndrome, and this can impact the brain and or coronaries. North-south syndrome is, in my view, the most insidious of the issues you can have with VA ECMO. And we've seen it. I don't remember that case that we did with that young kid, 19 or 21-year-old from Africa, had recently traveled to Africa. You know what I'm talking about? Super, super, super hyperdynamic heart, had a cardiac output probably of 15 liters. Or more possibly. Had his lungs were completely trashed. They cannulated him through a femoral venous drainage into the right IJ, which was, I think, an 18, and a femoral arterial of it was a 16 French. And so you could just imagine that situation. And of course, you know, the outcome was poor. Some factoids: ECMO will never capture 100% of cardiac output, no matter what you do. So I thought I'd throw that in for you, John. If the LV is failing, this can result in LV distension, which is a big problem because as the LV distends, the wall tension increases, your coronaries can't flow the blood down through the capillaries, you get basically a backup, and it results in ischemia and can result in much worse than that. This issue occurs 15 to 20% of the times for VA ECMO runs. Now, less if you're centrally cannulated, but it can still happen if you're centrally cannulated, especially if your aortic valve is just a little bit incompetent. It doesn't have to be grossly incompetent, just a little bit incompetent. And there's our ways of managing that, of course, with drains like a vent, Impella you could use, or you could try to use the intra-aortic balloon pump. Frankly, I don't think the IABP works if the heart is not already ejecting on its own. And if it's that big, you know, then I think that's an issue. You also have to be concerned about, and I didn't put it in here, you really have to be concerned about LV thrombus. You can clot your left ventricle off if the blood is in there and not moving and stays there for an appreciable length of time. So that's devastating, but I think that goes into, I think that's the catastrophic, so I think I messed up there. These are manageable problems, okay? So let me retract that, forget that I said it. VV, ECMO, common manageable problems, cannulation site bleeding, circuit clotting, and recirculation. Of these, you know, cannulation site bleeding is not hard to manage. Circuit clotting is really bad, and actually, you know, it could start clotting. So I didn't put it in the catastrophic category, but, you know, if it just clots completely off at one fall swoop, that's a different issue. And then recirculation and inefficiency of therapy is a problem, but there is this meter, the ELSO meter, which we've talked about, and it measures recirculation and oxygenator blood volume. So if you're on ECMO and your oxygenator blood volume started off at 220 cc's, or the MFU or the product information sheet says it's a 220 cc oxygenator, and you do one of these and it says you have 140 cc's, well, it's not Fritos that's occupying that space. It can only be one thing, and it's going to be clot. So you know that oxygen. And it's very interesting. You know, there's very little pressure differential or delta P from the inlet and outlet of an oxygenator until you get to nearly 70% occluded.
Yeah.
And so I don't measure the pressures anymore. Besides that, I can put my finger on it and get pretty darn close. These fingers are calibrated.
Yeah.
Actually I use my left hand, to be frank with you. But anyway, so that's there. Catastrophic issues, circuit clotting acutely, completely, big problem. Unless the patient has some reserve, probably not survivable, though I know some people have survived it. It can happen, I would still try. Circuit separation is probably catastrophic and probably not survivable. Decannulation, I don't think that's survivable. It's catastrophic. Equipment failure and you don't have a backup immediately available or a hand crank is a big problem. Unrecognized oxygen line disconnection, why it's so important to pay attention so that your patient, because I've seen patients that did not have a pulse ox on, and you're on ECMO and your oxygen line is hooked up to the wall and people are over there and it's very easy for that to become disconnected, and if it's at night and it's late and you're tired and you're not paying attention and there's the first thing you see is the patient is becoming hemodynamically unstable, but that is going to occur after the patient probably has suffered some potentially irreversible brain damage. So I think you have to be very careful and cognizant that that can happen. LV thrombus, massive air embolus, exsanguination from other causes. Massive air embolus can occur for a variety of reasons. The circuits that are designed and marketed to be used by ECMO specialists have no access ports to them whatsoever on the inflow or outflow side. But it reduces your ability to take advantage of this big circulation device for doing things with it that you may need. So perfusionists have those things, and you just really still have to be very careful with them. If you turn the access stopcock the wrong way, you're sucking a bunch of air, and it's just it's impossible to get out of a closed system. Very, very difficult. If somebody accidentally turns a stopcock on the other side of the bed and it's on the positive side, the first indication may be, and then they decided to go to lunch and said, hey, can you watch my patient for me? And again, you're outside of the room. Your first indication may be kind of like when your house starts flooding and you see the water lapping at your feet, only it's blood. And again, the patient is now hemodynamically unstable, and you're going to have to find this very quickly. So you have to be cognizant of all the potential risks that can happen. Because again, I want to go back to my one of my original conversations that I had, is that ECMO is a powerful tool, but there must be a destination. Indications, contraindications are relative. Yes, call early. But also, which I didn't put necessarily on the slide, is that you have to respect what this thing does. Again, I get, I've got a very strong, and you guys can jump in here. I think that's my last, no, it's not my last slide. Go back. Let me finish my slides real quick, because I want to discuss this. So ECMO can be a good choice, can be a bad choice, but I don't agree with that. I just put this slide up so that I could disagree with my own work. It could be right, wrong, or it depends. Well, I don't completely agree with that either. I think this is the one that I came up with that I mostly agree with. Now, I don't want you to look at that title. Forget that they're talking about inequality, because it's a political thing, but that's not political. The part that I want to get home is everyone gets different outcomes based on skills, choices, and to some degree luck. It's in parentheses because to some degree luck. But if you take all of those things into account, the outcome is almost proportional. And what that tells me is that ECMO, when you use it properly and you use it safely and you understand how it works, that your experience, your patient selection, maybe some good luck from the gods for the patient, proportionally those patients do well. And I'm an advocate of ECMO specialists. I do believe in the model, and that has more to do with resource management than anything else. And I do think they are smart people and can be very well trained. but it doesn't mean that I believe ECMO specialists should just go through a 5-hour or 2-hour in-service and now you just sit ECMO, or sit a few ECMOs and now you're an ECMO specialist. I've been training for 42 years to do this. You've been training for 38 to 40 years. Rodell, you've been training for over 20 years. John Ingram, you've been training for nearly 40 years. I mean, when you look at that kind of work that we've done, I don't want to trivialize it in any way, and I don't want to make it sound like ECMO should just be done by everybody and we need to just use it everywhere to save these patients.
Yeah.
I do think that its use needs to increase, but I think that having a good system in place, well-trained people, supervision from people who really understand it, not necessarily sitting at the bedside, but somebody like John, the way you do it, is right there helping, makes an enormous difference. John, what do you think? Rodell, your thoughts? I can't hear you.
I had my mic off. Okay, so yeah, you listed that slide a couple slides back that said, I think they were catastrophic failures.
Yeah.
The one there, we can talk about a lot of them, but one of them there that you said about the oxygen line,
Yes.
the oxygen line, unrecognized. Oh, I know a number of places now that do ECMO that check the oxygen line from the wall all the way to the blender and the blender to the oxygenator and must chart it every single hour. I see that more and more commonly. And the reason is because invariably the patient got transported on the O2 tank, came back to the ICU, everybody thought everything was fine. The perfusionist left to another perfusionist or the ECMO specialist or the nurse, and a little while later, all the lines go dark because there's no oxygen because the tank goes to zero, and everybody thought they were connected to the wall blender, and they were not.
I've seen it
And
happen.
that happens very easily.
Yep, I've seen it happen too. I've seen it happen too. Rodell, any thoughts?
No, I mean, it's patient selection is huge. I mean, we're doing more and more of these things, and you know, there are so-called experts out there, and they may not know anything about ECMO. Actually, I've had a couple of physicians come up to me. You know, they asked for the ECMO, and they're asking me like, "So how's the VV going?" I go, "Well, sir or ma'am, this is this is VV. You know, how's VA?" I go, "Well, this is VV. You asked for VV. This is a lung issue, not a cardiac issue,
right,
along with lungs." So it really has to come up with an expert, you know, at the head, you know, knowing what's going on. So it's become a problem. It's become a problem, and that needs to be a captain of the ship, if you will. So,
well, I'm telling you right now. I mean, you know, they make the medical decisions. I respect that, and I think we work really well with our physician partners, certainly. But you know, as far as my view about ECMO, I think that there's two things. One, by virtue of our training and our experience and what we do every day, it is almost second nature. But along with that second nature, you need exposure. And that is what we do every day. So we have a foundation of fundamentals that can't be beat, can't be competed with. And when we translate it to over here, that knowledge, then this experience, there's no doubt in my mind the people that are best prepared for managing ECMO patients and setting up exotic circuits and adding things to lines and managing different complications with, how do we need to route this flow? We're plumbers. We're plumbers. That's what we do.
Blood plumbers.
And we are blood plumbers. That's exactly right. Yeah, absolutely. So just so y'all know, we're going to take a short break if we can. I managed to get through all 3 of my lectures. So I did the patient selection, I did the complications part 1, and then I just was on a roll and did part 2 because John told me that his anticoagulation, or his anticoagulation, right? Yeah, his anticoagulation talk was going to run long. So instead of having him worried about time, I just got through mine because our audience is the smartest in the world. And I probably talked at 1,000 miles an hour. I probably didn't stop talking for a full hour, but I am about to stop talking now because I'm out of tea and I've got a parched throat and I need to pee on top of it. So we're gonna take a solid 10-minute break. Is that enough time, by the way, guys?
That's good.
10 do you want 10 or 15? Tell me. David?
It's up to you. We do 10 or we do 15.
Okay, let's do 10. 10-minute break. We're going to take 10 minutes and get yourselves another drink, whatever you need to do. Go take some more Zoloft. I might do that too. And we'll see you back here in 10 minutes, okay, with John Ingram's talk about ECMO anticoagulation. It's going to be epic, so make sure you get back here, all right? See you in 10.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Mixed Cannulae, expanding performance standards. High-performance Cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
And welcome back, everyone. 10 minutes has passed, and we're ready to get started right back up again. Well, I've got some more tea. You were able to get yourself something to eat, I think, a little snack. And we're going to go straight over to John Ingram, doing a Marco Rubio right there in front of us. And we're going to turn this over to you with your next presentation on ECMO anticoagulation.
Oh, and everybody, viewers at home, can realize that this is a pretty big topic that you can make into a very big topic. But hopefully, I'm going to hit all of the key points and the different things that we can do in the testing, and hopefully we can do a really comprehensive review for people doing ECMO, and maybe those who aren't doing so much, maybe we'll learn something. So I don't have any disclosures on this. Talking about adequacy of anticoagulation on ECMO. So introduction here. So ECMO anticoagulation is a delicate balance. There must be a delicate balance maintained between the anticoagulation to avoid thrombi and the coagulation to avoid bleeding from the cannulae and the surgical sites and the different things that you talked about, Joe. So despite efforts to achieve this balance, the frequency of both thrombotic and bleeding events remains high in ECMO. So anticoagulation is difficult to manage in this population due to the complexities of the hemostatic system that are compounded by age-related hemostatic changes, effects of the etiology on the illness, on hemostasis, and the blood circuit interaction. And that's saying a lot of things in that slide right there. So, Joe, I know you hit the indications. This is probably not an all-inclusive list, but indications for VA ECMO, cardiogenic shock, fulminant myocarditis, pulmonary hypertension with right heart failure, pulmonary embolus, cardiac arrest, medication overdoses, non-ischemic cardiomyopathy, post-cardiac surgery support, sepsis, induced cardiopulmonary failure usually. There's congenital heart disease malformations that are indications for VA. And as you discussed, Joe, bridge to decision for transplant or for VAD. And of course, patients must have some non-terminal conditions must exist as well. And then just the indications for VV ECMO, you have kind of your common ones and then your probable or possible ones. And of course, the common one is some form of ARDS, severe pneumonias, pulmonary contusions. As you mentioned, Joe, I saw in your talk, you mentioned alveolar proteinosis, smoke or chemical inhalations, people who have a severe bout of asthma. We've seen a number of those patients at our institution. Any type of airway obstruction or any type of aspiration will usually need a VV ECMO. So this is the most current ELSO statistics that I could come up with, January of 2020 on their website. And just to give people an idea of what is the survival and what is the discharge percentage of people that we do this to, right? So it has broken down there, the neonates, the pediatrics, and adults. But basically looking at neonates, pulmonary and cardiac, 87% survival, and 73% get discharged. So the venous support always has a higher percentage than the cardiac and pulmonary, but their cardiac is 69% discharge, 43%. If you look at pediatric, 72% survive on the pulmonary with 59% being discharged and going home. Cardiac side is also 72%, and not too differently, but 53% get discharged. But the adults, pulmonary is 69%, 60% get discharged, and only 59% on the cardiac, and 43% get discharged. But ECPR, we're still struggling a bit with that. Where really only 29% of the people ever get discharged from the hospital. So when you talk about ECMO, you really have to talk about hemostasis, and pretty much in the same breath. Hemostasis on ECMO is related to many things, but number one, the clinical condition, post-surgical bleeding, sepsis, hypothermia, causes disruption in the coagulation system. Hemodilution, you can have dilutional factors of the coagulation factors and so on. The constant transfusion of blood products once the person is bleeding. Complete imbalances can develop with your proper platelet counts and factors and fibrinogen. But you're giving the patient heparin, usually a continuous heparin infusion, throwing a whole monkey wrench into this whole management of hemostasis. When it comes to neonates and infants, they have an immature coagulation system, which means they have lower levels of antithrombin 3. And the pharmacokinetics of heparin, it's different with neonates versus adults. So ECMO and coagulation. So the ECMO circuit, first of all, it's not an endothelium. And so therefore, it absorbs proteins and platelets, to say the least. There's a whole cascade that goes on with the lying down of proteins and platelets and even red cells along this inner lining of our tubing and circuit. Well, the effects of coagulation, basically, this activated coagulation leads to a consumption of our coagulation products. So consumption is contact activation system, which is basically reactions following absorption of contact factors on a negatively charged surface. So the contact system factors are usually 12, 11, prekallikrein, and something called kininogen. Then the intrinsic system factors that are consumed are 11, 10, 5. Extrinsic system also, tissue factor, factors 7 and 5. Then there's fibrinolysis that occurs with TPA release, kallikrein and plasminogen as well. Then we have our complement activation. That's our innate immune response. And this causes damage to the endothelium, activates release of TPA, heparin, and tissue factor. Then you have platelet activation, which leads to thrombin, heparin, and PAF is a activated factor, platelet activation factor. And then your consumption factors, protein C and protein S, which, by the way, are factors to do with coagulation and vitamin K as well, and then antithrombin 3. So there's just really just a tremendous list of things that happen when our blood system comes in contact with the artificial surface. So just looking at some things when we initially go on ECMO and time along the bottom, and on the left graph you have your prothrombin factors fragments F1 and F2, and as you can see, it starts off, you initiate bypass, and right after 5 minutes, it spikes right up. These factors get activated and begin to get consumed. Your thrombin antithrombin complex, this is your AT3 combining with thrombin, which is indicating that you're having coagulation occur. And again, right after 5 minutes of being on ECMO, it spikes way up and pretty much stays that way and eventually trickles down a little bit over time. And at 48 hours, it's modestly elevated. But you've consumed a lot of them. And here's a similar one with platelets along the y-axis and time along the x-axis. And you can see a tremendous drop in your platelet count. And almost always, when we have patients on ECMO, we're struggling with very low platelet counts. So let's talk about anticoagulating these patients. And of course, the mainstay and the backbone that most people use by far is heparin. It's a naturally occurring glycoprotein. It's extracted from the lungs and intestines of pigs or cows. But by itself, it has no direct anticoagulant effect. It must have a mechanism of action which binds with antithrombin 3, AT3, and it stimulates this AT3. It stimulates its activity 1,000 to 2,000 fold.
Wow, I didn't know that.
So the dosing effect, if you look at a PTT, most people, you would want a 1.5 to 2.5 times the normal PTT, which puts most people in a range of 60 to 80 seconds is what you would use on ECMO for most people. If you use your ACT, most people are between 160 and 200 seconds. And what you're trying to do here is find a delicate balance, what I said in the introduction, of just enough anticoagulation where you don't have bleeding and you don't have clotting. You can look at anti-factor 10A levels. Desired therapeutic level there is usually 0.3 to 0.7, but it can be greater than that. You basically need to titrate these things until you have an effective clinical response. So the consequences of heparin can be bleeding. It can stimulate antibody production. You can have anaphylaxis, and you can have something called HIT, heparin-induced thrombocytopenia, which we're going to touch on a little bit later. So let's look at antithrombin 3. Heparin doesn't do anything in the absence of antithrombin 3. It's a serine protease produced in our liver. It acts as our natural inhibitor of coagulation, of the coagulation cascade. This is one of the main things that's preventing our blood from clotting normally in our system, the action of antithrombin 3. It directly inhibits thrombin, and it limits fibrin clot formation. It primarily affects the intrinsic pathway, and that would be factors 9, 10, 11, 12, and plasmin. And it prevents intravascular thrombosis. So when we look at our normal AT3 levels again, it's these levels are measured and are expressed and the percent of activity, and they're age dependent. An infant less than 1 month old would only have about 50 to 80% normal activity of AT3. It gets a little better as you get older. 3 to 6 months, it's getting close to 100%, but not until after you reach 6 months of age do you really get close to your 100 or more than 100% normal AT3 activity level. Now, heparin, as I said, stimulates this activity tremendously, 1,000 to 2,000 fold. So initiating ECMO significantly decreases our antithrombin 3 levels. That's a problem. Or we can also have hemodilution, which may dilute our antithrombin 3 as much as 50% or more. The antithrombin 3 may already be low due to the patient's illness, or they had a prior cardiovascular surgery, or as I just showed you, maybe they're a neonate and they already have about 50% less active antithrombin 3. So lots of times we discover that a patient has an antithrombin 3 deficiency once we give them heparin, and we find out that the response is very minimal. So how would we increase our antithrombin 3 in the case of not having enough or not having a high enough activity? Well, FFP, fresh frozen plasma, has always been, for many years and decades, the great go-to, and this will increase your antithrombin 3 levels. For every 20 milligram per kilogram, it'll increase it about 20%. It replaces other clotting factors as well in the FFP. Or you can give somebody thrombate. This is actual antithrombin 3 directly. And 1 unit per kilogram will increase your antithrombin 3 level about 1 to 2%, and a vial of it contains approximately 500 units. So you can do a calculation and try to find out how much you want to increase your antithrombin 3. I think I'm going to show you that in the next slide or two. Yeah, it's there. So the antithrombin 3, the thrombate, is prepared from pooled human plasma, and it's recommended that once you reconstitute it, that you only use it less than 3 hours, a 3-hour shelf life. You administer it over 10 to 20 minutes IV, and here's your recommended dose. If you have a desired antithrombin 3 of 100% and you're measured it, and it's only at a certain level, you take the subtraction of the two, multiply times the weight of the patient, and that you can figure out your recommended dose to bring you up to where you want to be. So what about some of our tests? And we measure anticoagulation on ECMO. How do we measure it? Well, there's at least 6 tests available. One is to measure our ACT, or activated clotting time. We can measure our anti-10A levels. We can do PTT. We can measure the antithrombin 3 activity as a percentage, as I mentioned. You can do an HMS, and you can do a TEG, a thromboelastograph. We're going to take a look at most of these. So let's look at the activated clotting time, ACT. Well, it's used to titrate heparin. It measures the inability of the blood to coagulate. It does not correlate with other clotting studies. And it's affected by the methodology, the user, the person running the test. It's affected by platelet count and platelet function. It's affected by hypothermia, and it's affected by drugs. And this is not an exhaustive list. So there's some drawbacks to relying only on ACT, and one reason why a lot of these other screening tests we're going to talk about have emerged over the years. Well, any real ECMO institution really should have a point-of-care ACT device at the bedside. It's considered pretty much standard at this point in time, and you would use a range of 160 to 200 as your ACT range, and you would titrate the rate. Maybe you would initiate it at 25 units per kilogram per hour, and basically once you reach your target of 160 to 200, you basically use your ACT as a trend. You see your ACT, was 180, then you draw it 4 hours later and it's 160. You're trending down. You'll up your rate of IV administration of your heparin up a certain amount and test it again, and hopefully you're no longer trending down, and hopefully you can keep it in the range. So that's basically what most people do. Well, the pros to this are it's basically easy. It's used at the bedside, a point-of-care device. It's cost, availability, and the comfort level is pretty high with most people using these. The cons is user variability. There's a lot of analyzer variability. And really, there's a poor correlation between ACT and your actual heparin level because so many different things affect your ACT. So let's look at what people like to do a lot is use the PTT or the APTT, which is your activated partial thromboplastin time. And this is a test performed to monitor heparin levels, and it measures the time it takes for a clot to form. It tests the intrinsic and the common pathway of the coagulation cascade. But it measures the integrity of factors 12, 11, 8, and 9. The normal range for a normal person not anticoagulated would be 25 to 35 seconds. You're going to see increased PTT levels are going to usually be seen in people with bleeding disorders because of their maybe deficient or not working one of these factors. Could be either deficient or defective. So therefore, liver disease decreases the production of these factors, and most people with liver disease have an increased PTT level. So let's look at anti-factor 10A activity. This has really been a hot one in the last few years to try to improve upon what we're doing. Well, it's a highly specific assay which tests only the in vitro functional activity of the heparin, not the entire intrinsic pathway. It measures the heparin effect via antithrombin 3 complex. It's more reliable than PTT for assaying heparin because it looks at the anticoagulation effect. It has a better correlation between outcome-based anticoagulation status and the anti-factor 10A activity than does a PTT. A normal range would be 0.3 to 0.7 for anti-factor 10A. So what are the complications that we run into when we're talking about ECMO, and it's in particular now I'm talking about complications with using heparin? You can have bleeding, of course, thrombosis, but you can have heparin resistance, and you can even have heparin-induced thrombocytopenia. So let's look at bleeding. Well, to say it's common is probably an understatement because it's pretty much, when it comes to ECMO, it's universal. If you're doing ECMO, you've encountered bleeding. Well, it's more common when your fibrinogen level is less than 50 and your platelet counts are less than 50. So we monitor these a lot on ECMO. Cannulation insertion sites are the most common site for bleeding. That's a little more common in VA ECMO than DV ECMO, and that's, of course, because you've got a high-pressure artery that's cannulated. The remote sites for bleeding are a little less common, but you can have wound site bleeding and incision site bleeding. And then, of course, the really bad ones are other remote sites which are internal, like brain bleeds, pericardial cavity bleeds, pleural space, retroperitoneal, abdominal cavity. And when you have these, you're taking the patient down to MRI and you're trying to figure out, CT, and you're trying to figure out, where the problem is and what are you going to do about it. You're on ECMO, you're anticoagulated, you open the patient, you're going to cause more bleeding. So these are really bad and challenging problems to have. So now, how are we going to treat some of this bleeding? Well, we can do a surgical expiration, add some sutures, compression. We can try administering fibrin glue to certain areas. Well, if we're deficient in certain factors, we can give cryoprecipitate. That would be for factors 8, 13, von Willebrand's factor, and it's basically used to replace loss of fibrinogen. You can give somebody fresh frozen plasma. This would replace factors 2, 5, 7, 9, and 10. And of course, in cases of DIC or in any case where you think you have multiple factor deficiency. And you can give activated factor 7. We've all heard of factor 7. This binds to activated platelets, activates factor 10, and aids tissue factor binding. You can try giving DDAVP. This is going to raise your factor 8, von Willebrand's factor levels as well. But you have to use this with caution because it can increase local TPA levels and cause fibrinolysis, and usually should be administered with some antifibrinolytic therapy, which would be something like aminocaproic acid, tranexamic acid, and this reduces plasminogen binding to the fibrin. And there's something out there, it's right now still in orphan drug status, I don't think it's released yet. It's actual just fibrinogen. It's called hemocomplitin, I guess is the name of it. And hopefully in the future, maybe we can find that coming our way. Well, besides bleeding, you can have thrombosis occur. We definitely see this quite often in ECMO. But the prevention of clots entirely is really not possible. We say that because every single oxygenator that's ever been sawed in half after an ECMO run, 100% have always found clots inside the oxygenator. Well, we try to desire an ACT level between, used to be very standard 180 to 200, and now a lot of people are using what I said earlier, 160 to 200. But 180 to 200, if you're worried about thrombosis, you might err on the side of a little bit higher there. It still does not guarantee prevention of clot formation. It actually slows the formation of clots. Your clots in the circuit are most common, whether you see them or not, whether you know them about them or not, they are occurring, especially in the membrane oxygenator. And eventually you can see decreased gas exchange efficiency when it gets a proliferation enough in the oxygenator. There's a lot of people that basically scan their ECMO circuit for every hour and chart it from tip of the cannula back through the circuit and back again. You're going to have to change the oxygenator out when the efficiency becomes intolerable. You can have clots in the patient. Certainly, if you do enough ECMO, you're going to have clotting that occurs in the patient. And we see a serious number of patients that, unfortunately, have a stroke, and we do see seizures. You can have coronary MIs. Patients are doing well, and then all of a sudden they go into severe cardiac failure. Maybe that was due to an embolus. You can certainly have renal injuries due to renal emboli, and of course anywhere really, your GI tract. We a lot of times have ischemic bowel, liver problems, and pancreatic as well. So these are big problems. Another problem with heparin is something called heparin resistance, and it's defined as the patient requiring double the normal dosing range, greater than 35 units per meter squared per day. And the etiology of this can be decreased antithrombin 3 level or its inactivity. And you need to run and check an anti-3 activity, and hopefully you can get that back in a stat request of 4 hours or less. And you can try replacing that with fresh frozen plasma or the antithrombin 3 concentrate I was talking about. And you can also, it can also be due to an elevation of factor 8, something called acute phase protein, which is not something I know very much about, but that is an etiology as well. So we can get even further problem with this, and this is something that's relatively common. It's certainly not uncommon, heparin-induced thrombocytopenia. And you have HIT type 1, which is really a non-specific decrease due to the heparin binding. It's not really a thrombosis risk, and it's really rarely problematic. Usually you can just give the patient more heparin. But when you get HIT type 2, this is the one we deal with that we worry about the most, and it's antibody-mediated reaction to the heparin. You have a dramatic drop in platelets, but hypercoagulation ensues despite the drop in platelets. Thrombosis formation is at high risk, and stopping the heparin does not stop this process. Stopping the heparin you're stopping the aggravation of it, but it doesn't. That is not a cure. You must stop the heparin, but that is not a cure for it. So we're going to look at this a little further. So it's more common when a patient has been prior exposed to heparin, and usually within a few months, usually after 3 to 6 months, patients that have been exposed to heparin and have an HIT reaction may not have an HIT reaction in the future. But if they're still within a certain window of time, it's because they were exposed already to heparin. It can occur from any type of heparin source or strength. It's definitely more common in adults, usually after cardiovascular surgery or because of cardiovascular surgery, they were exposed to the heparin. It's pretty rare in kids, but if it does happen, it's usually, again, because of CV surgery cases. And you don't see it till about 5 to 12 days after the heparin exposure has occurred. So here's just a nice image of a descending aortic graft. I think that was a graft there. And this is a patient has 9 days post-heparin exposure and is experiencing HIT type 2. And you see the clotting of the graft. They immediately discontinued the heparin, put the patient on argatroban, and 2 days later, along with TPA, you can see the conduit on the right is completely dissolved of the clot and cleared. And this is how serious HIT can be inside your patient. So what is the treatment? You have to stop all the heparin. Unfortunately, that's not a clear cure because stopping all the heparin does not reverse or slow the thrombotic process. You're just no longer pushing on the gas and promoting it even further by stopping the heparin. So you need to test and you need to check for heparin antibodies. It's an SRA test, and the SRA is really, if you're not familiar, it's a gold standard laboratory test for HIT. It is a platelet activation assay that determines whether a patient has heparin PF4 antibodies or not. And you must convert over to a direct thrombin inhibitor, either Angiomax maybe, or Gatroban. We're going to talk about a couple of those here in a bit. So therefore, you lead yourself into direct thrombin inhibitors. If you have to go away from heparin, this is our go-to. They directly inhibit the enzyme thrombin, factor 2A. There are 3 types of direct thrombin inhibitors, though. Most people might not realize that. And it's dependent on their interaction with the thrombin molecule. There's a univalent DTI, which binds only to the active site of the thrombin molecule, and that one is argatroban. There's bivalent DTIs, which bind to 2 sites on the thrombin molecule, the active site and a site called exosite 1. And that's your bivalirudin or your Angiomax. There's a 3rd class of DTIs called allosteric inhibitors, which are up and coming, and I'm not going to really touch on those right at the moment, because as far as I know, I don't think they're being used. Well, anti-10A, it's traditionally used to measure low molecular weight heparin, and it measures the concentration of heparin in the blood by inhibiting coagulation factor 10. Therapeutic level is usually greater than 0.3 to 0.7. It can be greater than that. You have to use it according to therapeutic response and clinical response. In a recent review of ECMO centers, about 60% of ECMO centers have tried or used anti-10A testing. So let's look at using a Thromboelastograph, a TEG. Well, this is a viscoelastic hemostatic assay that measures the global viscoelastic properties of the whole blood clot formation under a low shear stress environment. The TEG shows the interaction of platelets with the coagulation cascade, the aggregation, the clot strengthening, the fibrin cross-linking, and then the fibrinolysis that goes on after that. So just briefly here, not to get too crazy with this, but this is what a thromboelastograph looks like. And if you look at the left there, the great thing about the TEG is that it shows you exactly what the coagulation abnormality is. You don't have to throw the whole kitchen sink at the patient, giving them platelets, plasma, and cryo, and figuring, okay, it's got to be 1 or more of those. The TEG tells you exactly what you're deficient in. So if you look at the left, the R there, that is called the clot rate, and it's the time that it takes for the initial fibrin to form. And this is a normal range of 4 to 8 minutes. If this is prolonged, you have a deficiency in your clotting factors, and you only need to give the patient FFP. The next parameter there is the K. This is called the kinetics, and it's the time for the clot strength to reach 20 millimeters on that scale there. And this is a range of 1 to 4 minutes. If you have a prolonged or deficient K taking longer than 4 minutes to reach that 20 millimeter height of strength, you have a deficiency in fibrinogen. You need to give the patient cryoprecipitate. Now look at the top there, that's called the alpha angle, and that tells you the speed of the fibrin buildup or the rate of clot formation, and that is measured in a degree. It's called the alpha angle, and that measured degree there would be 47 to 74 degrees. If this is prolonged, you are deficient in fibrinogen, and you also need to give cryoprecipitate. So then we move back down to the bottom. You see the MA measurement there, and it says amplitude. That is the state of the clot strength. The stronger the clot is, the wider that graph is going to be. And the normal range is 55 to 73 millimeters. If you have lower than 55, okay, it's not a very strong clot, you need to give the patient platelets. This is a platelet deficiency. And then the last one there is called LY30, and this is a percentage decrease after 30 minutes of analyzing the clot. It's analyzing the fibrinolysis. It should be in a range of 0 to 8%. And if you're deficient here, you need to give the patient Amicar or tranexamic acid. So the great thing about this is you can manage your patient exactly according to what the problem is on your hemostasis and your coagulation problem. So if you look at that next slide, I'm not going to get into this too much, but just for people who've never seen TEG very often, these are abnormal TEGs, and each one of these you can look at and see where the deficiency is and what you need to give the patient exactly to correct the problem. So that's the really nice thing about a TEG. So what is the future here of what we would like to see with all these bleeding and thrombotic problems with ECMO? And I'm just going to read most of this to you, but many studies are looking at the various design at the histocompatible ECMO membrane. Coating the membrane surface with synthetic and natural polymers and endothelialization of the membrane surfaces are the two most important current research areas going on right now. In a recent study using radical polymerization on the PMP types of membranes, the one that we use most for ECMO, they found a reduced recalcification times and it significantly delayed the coagulation. This method significantly prevented the binding of the platelets and leukocytes on the surfaces. Go ahead, Joe. A healthy vascular endothelial tissue layer plays an important role in the coagulation process. The ultimate aim of membrane technologies on ECMO circuits would be to mimic the healthy endothelial tissue. Only after then can one expect to overcome the myriad of coagulation problems experienced during ECMO treatment. There are studies indicating membrane surfaces covered with titanium dioxide would facilitate the attachment of endothelial cells to the development of a monolayered endothelium. Thus far, this development of the endothelial layer that they have done on the membrane surface does not seem to produce any adverse effects on the oxygenation process. So this may be some things we can hope for in the future. And thank you guys very much for listening. I hope that was educational.
Very good. Excellent. In fact, I'm going to give you an applause.
I get a hand.
You do. You get a hand. You get a hand clap. Okay. So, how about if we do this? We're going to go Mike, and then Rodell, and then me. So, you have the floor with questions, comments, and whatever, and we'll open the phone lines up, which they are.
You know, one of the things that I've been noticing on when we decided to start changing out an oxygenator, we'll always say it's becoming less efficient. Does that generally, and we've noticed that sometimes it's the PO2 delivery that is deficient, or we will notice that the CO2 removal is deficient. In your estimation, John, which one of those happens first? And which one of them should we more be kin to looking at on our lab values that we get back? Or are they pretty much equal as an oxygenator is going to fail? It's the O2 that'll fail, or it's the O2 blow-off that'll fail?
Well, the answer is actually very, very clear. It's not 100%, though. I have seen it the other way around. But definitely you're going to have a lot more difficulty with your sweep effectiveness, and your removal of CO2 is going to be the first indication that your oxygenator is starting to fail. You're going to have to, your oxygenation will actually stay pretty good, especially in the beginning and for quite a while. But you're going to have to, you keep getting your high CO2s, you turn the sweep up, 12 hours later, your CO2 is high again, you're going to keep turning the sweep up. And almost invariably, before we eventually change out an oxygenator, we have our sweeps way up to 12, 15, and trying to hold on to that oxygenator for dear life. And at some point, you will then usually begin to see decrease in oxygenation for sure. Now, I have seen it the other way around, but a good 9 times out of 10, maybe even 95 times out of 100, you're going to see difficulty in removing carbon dioxide with your sweep efficiency long before you see oxygenation problems.
That seems to be what we're seeing too, and our experiences are mirroring that exactly, what you're talking about there. I had another question. I'll have to come back to it. It went out of my mind, and I'll have to come back to it and ask him again.
Okay, well, I want to stay on this.
Okay.
So, you know,
I remembered it. Can I, before I forget?
Go for it.
One of the things we used to do a long time ago was a practice of what we call sighing the oxygenator. Giving it maybe once every hour, every 2 hours, at least 2 times sweep gas bolus for about 20 seconds. The theory being that this helped dry out the membrane material, stuff like that. And I think that idea kind of has fallen by the wayside recently, over the last few years. Until very recently, what we've started to see is that incorporating that has allowed us to extend the life of our ECMO oxygenator. What's your idea about that?
Well, it's still pretty much considered standard practice to side the oxygenator. I've seen places that said they just really didn't think it was accomplishing anything, and they don't do it but maybe once a day or maybe once every 12 hours, and that wouldn't be uncommon. Some people may be doing it more than that, but I can tell you one thing for sure, that if you side the oxygenator and you see a drip or 2 or 3 of humidity coming down from your exhaust port, I would say that, you know, that there is a patient there that you should be doing it more and more frequently. Right. I wouldn't doubt it. I've not really had a discussion about it prolonging the life of the membrane, but that would certainly make sense, that there's some intellectual appeal to that. But I think it's considered standard practice to side the oxygenator with some frequency. And I want to bring up something, Mike, about the proper technique of siding the oxygenator, because I've seen this done and it's not an acceptable technique. But what you said is exactly right. You need to double or at least bring your sweep up to 10 or maybe even greater than 10 for 10 or 20 seconds, whatever you're happy with, and then bring it down to your normal setting. But I have seen places that what they did was take a clamp, instead of turning the sweep up what I just described and what you just described, they take a clamp and they clamp the green oxygen line just prior to the membrane, going to the membrane, hold the clamp down for about 2 or 3 seconds, and suddenly release it, basically creating a huge burst.
Yeah. Why would you do that?
Do not do that. That is dangerous. It is not an acceptable way to side your oxygenator. And I've seen that done in my travels, and hopefully that is not something that people are promoting. But the funny thing was, when I came onto my shift, the leaving perfusionist, departing perfusionist, did it real quick, and then pretty much was out of there. So I was new, and I was my first time at this account, and I finally didn't really say much, but I said, okay, well, I'm on the shift now, everything's going to be okay. Well, when the relieving perfusionist, who was different, different person in the morning did the same thing. And so I thought to myself, this is the type of thing that somebody decides maybe is a good idea, and then next thing you know, it becomes habit, and they teach other people, maybe younger than them, new or whatever, that this is a technique. This is not an acceptable technique. Have you ever heard of that before, any of you guys?
No,
I haven't.
I've
and
never heard of it. I would never do it.
No, I agree with you. That I can't say the words on air, but I think that's really dumb. Yeah, I don't know that I believe in sighing. And Rodell, we will get to you. In fact, why don't you go ahead next? Because I've got my own opinion about this. Let's stay on this topic. What's your thoughts?
Actually, it's not on that. I mean, it's basically about testing. I went to ELSO a couple years back, and Dr. Bartlett himself, he chooses to do an ACT out of all the tests. With all the testing methods that you had up there, he chooses an ACT because it's a whole blood test versus a PTT, which is just based on plasma. It was just kind of interesting, his thought process on it. I mean, I prefer a TEG. I mean, not all of our hospitals have a TEG, and not everybody is comfortable with reading a TEG either. I mean, I think it's gotten a lot easier nowadays because it just has, the life of a clot, on a graph.
It gives you a readout.
Yeah, it gives you a readout.
Tells you what it is. It actually interprets it for you. Gives you an interpretation.
Right.
They're pretty simple.
Yeah, it is very simple. It's gotten simpler throughout the years, but when I first started, I go, whoa, what is this? It was just a fairly new technology that no one knew how to read. There was a few of us that knew how to read it, and those were the hematologists, and it was up to interpretation. So I guess my question is, what are you using at your institutions?
Well, it's pretty common. This is what I would suggest, and I would answer your question. It's pretty common to use ACT in combination with a PTT. That's not a bad way to go. If you don't have anti-10A testing at your hospital, and like you said, a lot of places don't have a TEG, or just don't feel like they want to go through the trouble of doing everything involved with a TEG, because now it has gotten a lot simpler. But let me tell you, not too many years ago, it was quite involved. And but if you combine your PTT using 60 to 80 usually, and your ACT, you'll feel a little better about what you're doing, because you'll see times when the ACT falls within your 180 to 200, but your PTT does not. Your PTT is down at 50. And that's a little better education, that you realize you can't just go by the ACT. There's too many things that affects it, way too many things that affect it, actually. And if you, we'll comment about anti-10A, people do that, and it's a very good test, but it does have the, people who use it will tell you, a lot of times, sometimes it just goes all over the place. You'll be riding nice in between the 0.3 to 0.3 to 0.7, and for no apparent reason, it'll go off the scale, and then you don't really do anything, and you test it again, and you're back in the range.
Right.
Sometimes you can have this real up and down with that anti-10A, and I hope over the years that gets better, because that's probably a really excellent test too. So if it was reliable, more reliable, and I think if you'll combine 2 or 3 of these tests from time to time, at least once every 12 hours. A lot of times what people do is they'll start off with their ACT and PTT, and once after a day or two, once they've settled down, and every time you get that ACT of 190, your PTT is 70, and that keeps happening, then you can drop down and not do the PTT quite so often. Maybe you were doing it every 4 hours for the first 48 hours, and now you really feel you're on the rails, you're consistent, and you'll do the ACTs often, and maybe only do a PTT once every 12 or something like that, if you want to save trouble and cost. And so that's kind of a good way to go. I don't know. I mean, there's places that just go by the ACT, but we all know way too much about The ACT being just, you're too blinded by too many things.
Right.
You know, that can change it.
Well, if I may, if you'll allow me, a couple of things. In regards to the oxygenator, starting to not transfer oxygen or carbon dioxide, depending you're seeing your CO2 bump up or you're seeing your PO2s drop down, that too can be multifactorial, right?
Yeah.
You can have a higher CO2 production for some reason. You could have a higher O2 utilization for some reason. You just don't know. And you have to sort of assess, I think, all of those things in combination. But I also think that, when you consider the pore size of an oxygenator, it's the pores, because it's a microporous, right? Microporous hollow fiber membrane, are about 700 angstroms, which is very, 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 very small. And if you have a large inflammatory mediator process going on, you're in a cytokine storm, which a lot of these patients do have very hyper immune issues going on at the time. Inflammatory processes going on, SIRS, they have, systemic inflammatory response syndrome, that those molecules will occupy that space. They will adsorb to the membrane material itself. And essentially what you get is a clogging of that membrane. Now, in regards to sighing the membrane, and in deference, John, to you, and in deference to, I know, we are technically all old timers here, we got a youngster with us, but we're all, he's still, for a youngster, he's still got some old, he's got some he's got some cred and years behind him. I don't think that makes sense. I think that whatever humidity fluid you see is condensation. The port is open. You have constant gas flow going through it. And I think that, of course, it's generally at the bottom, right? In gravity, it just drips down and then it comes out. If you are having a problem with hyperlipidemia, and your membrane, even if it's a PMP membrane fiber, it can still do it. It's going to do it a lot worse with polypropylene, but it's going to still do it with PMP. If you see that you're starting to get even a little bit of foam, that's a totally different phenomenon, and that has to do with the membrane material swelling and those pores getting larger from the swelling of the membrane itself, allowing plasma to be able to leak through it.
Right.
The other thing that I would like to say, if I may, again, in deference, I don't feel that, I think an ACT is very good because of the speed in which we can get a result. So if you are initiating ECMO on a patient and you give the patient a bolus of heparin, and then you initiate ECMO, and just before you initiate, you can get an ACT. You know very quickly if it's over 180 seconds, because if you have to send a PTT, that's going to take time to draw it, put it in a vial, send it down to the lab, wait for them to run it. They're going to have to smoke cigarettes before they go run it, and God knows what else they do before they give you a damn result. So you're always waiting forever for a stat, right? That's probably one of the biggest reasons nurses burn out, is the frustration in being able to just get results back for everything and anything. It's horribly inefficient systems that we have. But ACT is quick. After that initial ACT, and you are safe to go on ECMO, I think low-range ACTs have such low specificity and accuracy. They're so, the range of error is so large. I just don't do them at all. I do PTT only, And that's, I think the APTT is a much more precise, let's say the precision is what I meant, not necessarily the specificity, but the precision of an ACT is poor. The precision of a PTT is much better, and I think more consistent. I don't do them but every maybe 6 hours, once we're stable, every 6 hours. Sometimes we go to even every 8 hours because I believe in not having basically a blood test anemia, that results in sampling anemia, where you're just doing so many tests, it's unnecessary. You just do too many of them. Now, you need data, you need information, but I think sometimes you can overdo it. The other thing that I wanted to mention is on the heparin drip, once we have gotten to some steady state, notwithstanding John's very good point about A23 and how those levels can influence the heparin activity, okay, and the various things that affect that. Once I get to a PTT that I'm happy with, let's just say it's 60. 60,
good number.
And I wake up tomorrow, or I'm still there, and I slept with my eyes open all night, and it comes back for some reason at 52. Well, am I going to treat it? Sometimes I will, sometimes I won't. I will repeat it. I'll wait an hour and repeat it and see what it's doing. If it's still low at 52 and it wasn't just an anomaly or some other reason for it, then I like to give a small bolus as opposed to going up on the drip. Because I think when you you've got a drip that's been steady state, you give a bolus, it bumps it back up, and I've found in a lot of things, including that you tend to see it go back to being stable. It may drift down over time again, but then, maybe a little bit of a bump up. But what happens is there's a delay. You go up on the drip, and then you run another test, and it ends up being maybe not exactly what you wanted it to be, so you go up a little bit more, and then it's over what you wanted it to be. I'd rather bump it up with a bolus. That's my technique. So do you guys want to comment on those comments that I made? Anybody want to jump in? John?
Yeah, Joe, I just wanted to say, if you love that technique, you would probably really love using Angiomax as your anticoagulant on ECMO, I'm talking about, because I know centers that exclusively use Angiomax. Now, granted, it is very expensive, so you have to accept that. You have to digest that. If you can't digest that, then you go back to heparin. But if you digest and accept the fact that it's very expensive, but they use it exclusively. They don't use heparin anymore. And the one thing that's great about that, if you'll monitor ACTs and PTT with some frequency, like I just said, and once you get your levels just right with your Angiomax, let me tell you, you're good to go for a long time. You don't get these up and down swings, and if you start to see a little bit of a downtrend, you knock it up just a little bit, and you come right back into your sweet spot. You don't have to worry about heparin resistance occurring over time. You don't have to worry about a development of HIT. You don't have to worry about your antithrombin 3 being lacking because of being consumed on the ECMO. It's a pretty nice drug. Unfortunately, it's very, very expensive.
Yeah, and that is a big problem. But ECMO is expensive. I mean, ECMO is not a cheap therapy. And bleeding and thrombotic complications are very expensive, and that's actually their justification. That makes it worse. Now,
the downside, so if you think about having a bleeding or thrombotic complication because you used heparin and you just didn't have good management of your hemostasis, Angiomax maybe doesn't sound like such a bad idea. But I will tell you this: there's no antidote for reversing it. You just have to wait over time.
But it's got pretty short. It has a very short half-life, though, doesn't it? I don't remember exactly what it is, but I think it has a very short half-life.
If I remember, it's like 40 minutes or something like that.
I think it's 30 to 45. I think it's 30 to 40 minutes. Rodell might know.
Yes, I think it's 30 to 40.
30 to 40,
yeah.
I think so.
But it seems to me when we were doing the trials a long time ago, it's by my bio, it's stayed very strong with its anticoagulation properties, even at very low levels.
So you had to get it not just a half-life, you had to get like 3 or 4 half-lives
Yes.
before you were there.
Before
you're
you
talking,
were there.
You're
Yeah.
talking several hours.
Yeah.
Yeah. And that
That's what
could
we-
very well be,
what
yeah.
we noticed.
But you know, most of the time, I know Heparin is a little shorter than that, but Heparin's 90 minutes, isn't it? 90
Heparin
minutes?
is 90 minutes, yeah, 60 to 90 minutes. Yeah.
And so, you know, I mean, I don't know. I mean, it's pretty rare because if the dosing is that low, I mean, it's pretty rare. You know, you decannulate, they turn the heparin off, but they don't.
That's
they
what
don't. You know, we don't ever give protamine. I mean, that would be for that. I mean, I wouldn't think so. So I guess it would depend on what they're planning on doing. You could probably, if that's the case, and you can time it out, and you're VA and you're going to do arterial, then you'd probably turn it off a little bit ahead of time. Let it get down to where you're maybe 2 half-lives into it, and then decannulate and address closing the artery or whatever it may be, address your bleeding issue. Then it may be a little bit better. And in Jeff's experience, you are correct. By the way, Mike, he said you are correct. I'm assuming you mean about the Angiomax.
Yes, it's a very strong, it's a very good drug, very strong. But yeah, you do have those problems, and it's always kind of, you know, you're hoping that, as you probably do, is that when you start to turn it off, you sure hope that your surgeon's going to get there in time to take the cannula out and get them off ECMO. That's always a little sweat right there when you turn the Angiomax off and hope that people are going to be there in time to take that cannula out, because
That's very true.
It's tight. Sometimes
true.
it's very tight.
Yeah, that's very true, and that's very concerning, especially if you are, you know, big. You know, you have to always consider, and I try to tell this to them. You know, yeah, okay, we're anticoag. You know, we are flowing, because they'll say turn the heparin off, and we'll just run it down, and you're flowing. Just keep your flow up, and I'm like, yeah, that's fine, but remember, there's the outside of this tube that's going all the way up this patient's vascular system, and that's a lot of surface area. So when you go pulling that thing out, you can end up with a big giant, essentially like a DVT that's now broken loose, and clot externally that just gets left behind. Just strip it right off, or you can do it into the arterial system. I mean, it can happen, and that I think is a reason. I wanted to talk one last thing about the scanning the ECMO circuit. So, and I've got a lot of experience on this. If you see, and of course we can debate this all day long, and I'm not trying to make fun of anybody or company here, but nothing in our body is square. We don't have, lungs aren't square, blood vessels aren't square. We don't have square organs for a reason. But if you see clot, little teeny black dots on that type of lung, or any lung, on the arterial side, you have a big problem. And most clot starts to propagate from the in deep and just slowly grows out. So you can look with a flashlight all you want, but blood, unless you have a crit of 12, is by and large opaque. You can't see very far in there. And that's why, and I don't get paid by these people, so I don't have any disclosures either. It's not like Transonic pays me to be their spokesperson, because they don't. But it makes so much sense to me, and I believe very strongly, and I've said this before, that it should be a standard of care to measure the oxygenator blood volume, because that's going to tell you what your clot load is, number one, and it'll also tell you whether or not obviously your anticoagulation strategy is working or not. So it's going to give you that information. It's going to give you recirculation if you're VV, obviously not if you're VA. But I believe in that. I believe in TCD. I think we do not use imaging, essentially, electronic imaging, not direct visualization, but we use imaging techniques to assure good perfusion to the brain, and that our oxygenator, our circuit, first of all, and is working efficiently at the highest level it can, or an acceptable level, we'll say, and that our oxygenator is not developing a clot load. I think that's something that I feel very passionately about, and may not see it in my lifetime, but I'm going to continue to advocate for those things because I think they are extremely important. Rodell, thoughts?
No. Those are excellent points, actually.
Joe, can I chime in on this flashlight with the clot thing?
Yes.
Just about every place I've ever been, and there's been quite a few, are pretty religious about this flashlight looking for the clot thing. And I have yet not a single place that I've ever been when I ask them, okay, and they're charting, there's X small clot in this corner and it's this thing over there, and they're charting this and they're looking at this every hour. And I've asked every single place I've ever been, well, let me ask you something. You've got these little clots here and there. Are you going to do anything about it? No. So the next day the clots are bigger. Are you going to do anything about it? No. The next day the clots are gone.
Oh, that's the best part. Yes,
and now everybody's happy. Okay, great. We no longer have. Well, I said, well, do you realize that they went somewhere? I mean, is your theory that the body fibrinolyzed them? Is that your theory, so you feel better? Or do you think they got up and moved with a pressure of 350 coming through your oxygenator? I'm pretty sure they probably went upstream. But now I've never yet seen somebody. If your therapeutic PTT or ACT is being met, whatever your protocol is, and you have these little dots in your oxygenator, nobody is doing anything about it. Nobody's upping the anticoagulation dose. Nobody's. So to me, I really am not big on this looking in the flashlight thing, because you're not doing anything about it. The only thing that's happening is it's giving you something to talk about when you go on your lunch break, I guess. Because I've even seen long strings hanging off a connector, interior. And then nobody changed the connector out. And then a few days later, it's gone, and everybody's like, "Oh, I guess we cured it." Cured what? It left.
I can make it go away easier.
It didn't go away on
Give me a clamp.
Yeah, just
give me a clamp. I'll just whack it. I'll whack that fibered strand right off of there. No problem. But yeah, I agree with you 100%. I think flashlights should be banned, except for use to see in the event of electrical failure, and you need to see that they should be banned from use to look for clot in your ECMO circuit, because you're not going to find it. And if you see those little dots and they're on the arterial side, you have already been embolizing the patient. And that oxygenator needs to be changed. And when you do, prior to reinitiating, as the whole process is happening, you need to give that patient additional anticoagulation, whether it be more heparin, whether it be switching to something else. You have to do something. You cannot leave it like that. It is very bad.
I've seen clots on the entrance side into an oxygenator, but not on the outlet side of the oxygenator. And the one that we used to use, you can see that quite readily.
A square one. Who ever thought that let's just make a wall, and we're going to just drive the blood into a wall, and that's going to make it, with corners. Yeah. Where do you think the clot's going to start?
It's like Wile E. Coyote hitting the wall. I mean, it just spreads out just like that, and it's like.
Yeah. It makes zero sense. Now, with that said, and I don't want to dog this, I don't want to dog any companies, they have an exceptionally good tool for air transport. So I don't want to dog their technology. I'm not trying to dog them. I think that the design of the oxygenator was poorly thought out, but for air transport, their tool is a very good tool. It's extremely portable, very lightweight, very functional, and it's good for that.
Yes.
If you have a place that is, you're keeping the patients there, use a round oxygenator.
Yeah.
Joe, you have two things to think about with this square oxygenator particular company. The one that is not integrated with the pump, which is true of what you guys are saying, but the one that is integrated with the pump, right, the red one, the outflow of the pump has 4 outflows, and they all go to the 4 corners. It's not doing what the white one is doing, where it's slamming into a wall and spreading out, and hopefully some of the flow, makes it to the corners enough to not have stagnation, which is probably pretty unusual.
Well,
but
that's really good.
One,
that's really good, John. So the 4 corners develop clot, and then as you continue to pump at it, it just keeps chipping away at it and eroding it. So that's a good way to keep the oxygenator clean.
Yeah, I don't know about that, but I just know that the integrated pump.
I have strong feelings about square organs.
Flashlighting that goes on, you can't even see the pre-membrane clots anyway, or in the pump. You're only looking at post-membrane clots. So by the time you see those, right,
it's a done deal, exactly. Okay, well, let's see. Those were my comments. Oh yeah, and you were talking about coagulation. I can very quickly say this. I've been talking about what I call subclinical coagulation. I've been saying that, I've been using that term for 30 years. That when you have ineffective anticoagulation and you're on, let's say, full cardiopulmonary bypass, or in this case ECMO, and I started thinking about this years before ECMO, you will start to consume your clotting factors, but you won't see these clots. You might see, and you've seen it on pump before, where you start seeing those little fibrin strands against your oxygenator. Those patients bleed post-operatively bad.
Yeah, they do.
And so inadequate heparinization, even though you don't see clinical clot, you don't see gross clot and have a catastrophic event, does not mean you are not consuming a lot of clotting factors. And I call it a consumptive coagulopathy. That was kind of the way I described it. John, what do you think of that?
Yeah, that's what goes on with these anticoagulants. With heparin, for example, if you have a 12 or 13 step coagulation cascade, it only blocks it at 3 or 4 steps. The steps are in between the ones that it's blocked. Those are all still getting activated and being consumed. When you say consumed, they are turning from an inactive state to an activated state, and being used as though they are forming a clot. Unfortunately, the clot never ends up at step 13 because they're blocked at 4 different points, but all the in-between points where 2 or 3 are together and not being blocked are all being consumed because no anticoagulant can stop them at every step of the way. And the platelets get activated, and then they're going crazy, and that's why you have low platelet counts. Besides they get sequestered in the liver, but they're all over the circuit. And so you have a lot going on with this anticoagulation. We are probably millennial away from having the perfect anticoagulant.
Probably so, but at the same time, heparin was the key to Dr. Gibbons being able to successfully put a patient on extracorporeal circulation and Cecilia Bokovac and have her ASD repaired, and went on to live a wonderful life. But that was all because of the invention of heparin. That was one of the biggest problems that they had, was solving that with extracorporeal circulation, was anticoagulation.
Well, and unfortunately, we had the perfect reversal, near perfect reversal antidote for it, which I don't know how many anticoagulants out there even have a reversal agent.
Yeah, I guess
the warfarin with vitamin K. I guess vitamin K does reverse the vitamin K inside.
Yeah, but I'll tell you what, I've talked to people about vitamin K. Like if you're talking about if you're using warfarin, You can use vitamin K, But I know a lot of people, a lot of surgeons who have told me that they're very afraid of using, I guess it's aquamaphytin, right? Vitamin K is aquamaphytin. I think that's how it's marketed. They're very afraid of it because they've seen giving it to patients who they needed to reverse some of the warfarin, and they've just gone hypercoagulable and just died. So it's kind of a scary thing. But then you can have protamine reactions too. How many times have we gone back on pump because the patient crumped because of pulmonary hypertension or whatever else with protamine? It's a good antidote. I don't know that it's perfect because it carries with it its own risks.
Yeah, that's why I said near perfect, because of the reactions.
Yeah, you said exactly. I'm sorry, I missed the near part. Rodell, final thoughts? Only this time, final thoughts means guys. Final thoughts means final thoughts. Because the last time I did this, I said final thoughts, and then no one was saying anything, and I started talking again and forgot that I had said it was final thoughts, and we went back around. We had like a second round of final thoughts. So Rodell, final thought.
No, it's really interesting, talking about that oxygenator that you really can't see the clots in,
You can't see it in any oxygenator. No oxygenator.
Ostrich with burying their heads in the ground. We're not going to do anything about it. I mean, it's unfortunate, but it's just, it's just part of, clinical activity.
Yep. Got it. All right. John, final thoughts?
Yeah, I just can't believe we're at the end of this COVID-30, and I was wondering what is the final kickoff tomorrow night exactly? What's the show going to be?
Tomorrow is going to be, that's a really good question. Thank you. It's going to be just a conversation with Joe. If you'd like to participate, you can. We're just going to turn the phone lines on. It's only 50 minutes long. You all know me. I can talk for a solid hour with no problem, all right? I can do that. And it's basically what we learned about perfusion services delivery over the last 30 days. And it's going to be what I experienced myself, lessons and information that I've learned from people like you, Rodell, Stephanie, Nate, John, Praveen up in New York, and other colleagues of mine in different places around the country that have gone through this episodic disaster, really, that we have all experienced. And probably have some thoughts, too, about, did we really do the right thing? Cancer diagnoses are way down right now. Well, does that mean that we cured cancer? Does COVID-19? I don't think it means that. I think it means that people didn't get diagnosed. I think the same thing with heart disease. We all talk about, time to balloon, how important that is, but yet we have seen a gross reduction in patients coming to the emergency department with ACS. Well, where are those patients? Did COVID clear? Does it cure coronary disease? I don't think so. How did we manage these patients? Are we thinking about it? What have we done in our practice that's different? Being out of the room while the patient's being intubated now, and all of these things, and managing COVID patients that are on ECMO. There's so many lessons that have been learned from this that I think just being able to discuss them in an open forum, and if nobody calls in, I can discuss them with myself. John, if you want to call in, you can maybe help me with that. But, that's what tomorrow's program is going to be.
I scratch my head every day wondering where all our patients went. Where's all of our aspiration pneumonitis? Where's our ECMOs that were, breathing noxious fumes? Where is our flu A and flu B ECMO patients? Where is our post-cardiac cardiotomy patients? Well, that we know what happened there, but where are all those patients? Where we had all kinds of ECMO patients that weren't COVID, and all of a sudden we don't have any, and we have all, COVID, but where all these patients went, I still don't understand where they all went.
Well, I mean, I can speculate, if I may, if you'll give me the latitude to do so. I think they went to the I think they went to the angel room. And I think that when the final analysis of this is done, we're going to find out that the mortality rate of diseases that previously had very high survival probability, that the death rate amongst them will exceed the death rate, the death numbers that have unfortunately and sadly succumbed to COVID-19. That's what I fear most. Mm-hmm. John?
Well, I mean, I want to save it for tomorrow's show, but I can tell you that the drug usage, the alcoholism, the poverty, and the homelessness, 24 or 36 months from now, when we look back, maybe even 5 or 10 years, when they look back, I think they're going to see a frightening increase in the casualties of alcoholism, homelessness, drug usage, depression, and poverty. And in fact, it was about the first or second week of the COVID crisis. They were interviewing a liquor store owner somewhere in Nowheresville, USA, and they were saying, and it had already been going on now 2 or 3 weeks, that every single day their sales are equal to Christmas or Black Friday since the onset of the COVID. This liquor store owner was interviewing on a regular TV station.
Well, I mean, can I ask? I mean, and I don't want any answers unless you want to share one, but I've just got to ask this question. What makes a liquor store, Home Depot, Walmart, Target, Lowe's, and I can think of a couple of other things, more essential than a gym, church, or sitting on a beach separated by, 6 feet or more at least, if not even more than that? So who would open a beach and say you can walk, but if you stop and sit down, you'll be arrested? How in God's name does that make any sense? I don't know. I don't know. I don't think it makes sense. So I'm trying to understand, how is a liquor store essential, but a dentist isn't? And you're dying with a horrible toothache. There have been people commit suicide over dental pain. It can be that excruciatingly unbearable. It has happened. So yes, it's going to be, so that's going to basically be our 50 minutes tomorrow, is how in the hell did we get through this as a healthcare delivery industry when we had, from our perspective, very few COVID-19 patients, but a complete, just like almost 3 weeks of no heart patients at all. We went from an average of 5 hearts a day to maybe 3 hearts in 3 weeks. All that's an incredible drop, and not any ECMO, other than maybe a few here and there. We had a couple, but comparatively very, very low. Orthopedic cases, spine cases, hip replacements. I mean, grandmom still fell and broke her hip. We didn't see it. Gone. Where'd she go? She bleed to death? She just lived with a broken hip? You can't live like that. But we'll talk about it tomorrow. Okay, final thoughts, Mike? Mike didn't get a chance to go. Okay. Calm down.
John, I'm on your side. I'm going to sign my oxygenator. I think it works. I'm an old-fashioned guy with that one. I'll keep that one. But really, the discussions about ECMO, it's going to do nothing but get more and more and more as we go. Who knows? Maybe we'll even be a patient on one day, Joe.
I have "Do Not ECMO" on my chest.
And I think your point of trying to figure out a good economical way to test oxygenators for clot is probably not going to happen in our lifetime, but I think it's going to be standard of care one day, and I think we will see those in the future.
The device is cheap.
Yeah.
Okay, so everybody now has made their final thoughts, and I'm going to zip it. I'm going to see you all tomorrow at 5 o'clock. So same time, same channel. I want to thank our incredible panel today and faculty for their contribution to this program, your experiences, your thoughts, everything. I'm truly every day I work with you people, I feel humbled that I have the opportunity to be able to have a professional relationship with you and a friendship. You're all really nice people on top of it. Some of the nicest perfusionists I've ever met, because most of us really aren't very nice. I mean, I think we're exceptions, which is nice. But with that said, it's been a pleasure. It's been an honor. Hopefully all of you in the audience have truly enjoyed and learned something from today's program. And we all, especially me, but we all want to thank you for allowing us to come in through your phones, your tablets, your computers, whatever it may be, and be a part of this. We just want to thank you. That's it. You know, we did this to be helpful, and we're getting the return on our investment by your involvement by watching. Would like for you to call in more, but you are chatting more, so I appreciate that. Don't forget to subscribe. Don't forget to give us a thumbs up. Send me an email, and we will see you all tomorrow, same time, same station, and we're only 3 minutes short, so we did really good. Good night.
Mixed Cannulae, expanding performance standards. High-performance Cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP Venous Cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo Cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The Point of Care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.